to lead us on prayer?
Pray for our nation. Pray for those who are sick. We ask for your healing mercies, Lord. We pray for our institutions, our agencies, our healthcare system, and our leaders. Guide them, Father, as you only can towards the right decisions. We ask for your leading for our purposes in our lives, something we have created each of us to do. Help and guide us, Lord, to do whatever you want us to accomplish today. In Jesus' name we pray. Amen.
Amen. This meeting is now called to order. May we hear a motion? Do you have Kong Dahlia?
Good morning, Chair. I move to dispense with the calling of the roll. So move, Madam Chair.
There's a motion to dispense the calling of the roll.
Second.
Duly seconded. Is there any objection? Hearing none, the motion is approved. Would like to recognize first the presence of the following members. We have Representative, of course, our Vice Chair, Dalia Loyola, Representative Adrian Ebcas, Representative Irene Saulog, Representative Sara Elago, and Representative Mickey Violago. Ma'am Sylvia, can you recognize the resource persons present today?
Yes, ma'am. From the DOH, we have, I think Yusek Mario Villaverde will follow, ma'am. We have, for now, Mr. Julius Cesar Castillo. From PhilHealth, we have PCEO and President Attorney Dante Gueran. We have SVP Attorney Jose Marie Tolentino from the Legal Department. We have SVP Attorney Maria Emily Roque of the Fund Management. We have SVP Nerissa Santiago from the Actuary. We have VP Lemuel Untalan, Member Management. We have VP Dr. Shirley Domingo, Corporate Affairs. We have Area VP Walter Bacaresa, Area VP Attorney Alfredo Pineda II, Area VP Attorney Rex Panti, PHIC CAR Dominga Gadgad, Region 11 Rosana Paraguya, Region 8 ARVP Rosario Suyo. We have PHIC for a while, ma'am. Edgardo Faustino, PHIC for a Dr. Santiago Abricia, Miss Genevieve Masahud, Dr. Jonathan Ele, Miss Lisa Magno, Mr. Delio Aceron, Miss Lita Flor Marasigan, and Miss Juliet Diaz. From the Philippine Medical Association, we have President Dr. Benito Atienza. From the Association of Health Maintenance Organization of the Philippines, or AMOPI, we have Executive Director Dr. Carlos De Silva. We have from the Department of Finance, we have Mr. Job Desmonte. From the Department of Labor and Employment, we have USEC Executive Director Stella Banawis and Mr. Jonathan Villasoto of the Employees Compensation Commission. From the DSWD, we have Attorney Katrina Grace C. Ongoko. From the Governance Commission for GOCCs, we have Attorney Carlo Paolo P. Murcia. That's all, Your Honor.
Thank you, Ma'am Sylvia. Do you have guests from COA and ARTA? Did you recognize
Yes, ma'am. We invited them, but they're not yet in, ma'am.
Okay, kindly follow up. Okay, good morning again. This meeting, the first for the Committee on Health for the new year, is being called upon amid the resurgence of COVID-19 cases in the country, particularly here in Metro Manila area and its neighboring provinces. The committee has initially thought of holding a hybrid meeting since cases were down before the holidays. Based on the DOH COVID-19 case bulletin, the positivity rate 3 weeks ago was below 1%. 2 weeks ago, it was below 5% and still within the WHO benchmark. And last week, it was already over 40%, which is a new record high. This is the reason why we are back to pure virtual meeting, the one that we have been doing since the pandemic. We are concerned that the country went from record low to record high in just 2 weeks, and I hope, as I am sure every one of us is also hoping, that this week, or at least in the coming weeks, will be better for us Filipinos. The committee joins those who pray for the speedy recovery of those afflicted and continued health and protection of those who are well. Be that as it may, as Senator Edward Kennedy said, the work goes on, the cause endures. And so today, with us are various agencies of the government led by the Department of Health, along with PhilHealth, from Commission on Audit, from Anti-Red Tape Authority, as well as the hospital groups, from the Philippine Hospital Association. We have guests from Private Hospital Association of the Philippines, together with Philippine Medical Association and the Association of Health Maintenance Organization of the Philippines Incorporated, or AMOPI, to discuss the latest developments on PhilHealth reimbursements and payments to hospitals, which will perforce touch upon or revisit the various PhilHealth circulars on the availment of COVID-19 related benefit packages as contained in several circulars, such as PhilHealth Circular number 2020-0004, or enhancement of packages related to coronavirus infection, PhilHealth Circular number 2020-0009, or benefit packages for inpatient care of probable and confirmed COVID-19 developing severe illness or outcomes, and PhilHealth Circular number 2020-0011, full financial risk protection for Filipinos, health workers, and patients against coronavirus, and PhilHealth Circular 2021-0008, or clarification on the coverage of COVID-19 patient benefit packages, and PhilHealth Circular number 2021-0016, or the application of debit credit payment method to facilitate the settlement of accounts payable to healthcare facilities during the state of public health emergency due to COVID-19 pandemic, which was the subject of House Resolution 1966. The PhilHealth, during the committee's previous meetings, have already given a briefing on these policies. Today, we are expecting to hear updates on these circulars, in addition to the latest development on the issue of PhilHealth Circular 2021-0013, or the controversial temporary suspension of payment of claims policy. It is important to note that on November 9 last year, PhilHealth informed the committee that it has adopted some of the recommendations of the hospital groups. These include increasing from 3 to 10 days of non-extendable period for healthcare providers to answer the fact-finding investigation report, the TSPC order to take effect on the date of receipt of the order, the limited coverage of TSPC on the claims of a facility, and the revised period of TSPC from 120 days to possibly 60 days. Perhaps PhilHealth can give us an update on these points and other related matters. Incidentally, which is why COA is here, or Commission on Audit is here, the state auditor has previously recommended that DOH management and PHIC Board of Directors collaborate in instituting specific policies addressing the recurring problems on denied, unpaid, and delayed PHIC claims. What particular policies came about as a result of this recommendation? Also, hospitals were urged to analyze the causes for the disapproved or denied claims and make use such information in the processing of future PhilHealth claims to improve reimbursement rate. This committee will highly appreciate if the concerned agencies can walk us through their findings and the latest innovations regarding reimbursement of PhilHealth to hospitals. Without belaboring the issue, it is imperative to cast against the backdrop of today's deliberation the report that some private hospitals are cutting ties with PhilHealth, along with the reported plan to hold a PhilHealth holiday, which eventually brings us to related discussion on PhilHealth restructuring as proposed by Representative Stella Luz Quimbo of the 2nd District of Marikina City through House Bill number 7429, entitled An Act to Address the Social Health Insurance Crisis and for Other Purposes. The bill seeks to grant the President of the Philippines power to privatize any or all segments of PhilHealth and proposes to establish Executive Legislative Social Health Insurance Crisis Commission that will carry out the necessary steps towards the reorganization of PhilHealth and contract a transition management team from a private corporation or management consultancy firm to assume the implementation of that national health or national insurance program under the Universal Healthcare Law. Hence, under this scheme, the President may abolish or create offices under the agency, transfer functions, increase the salary of workers if necessary, impose policies instituting cost cutting, among other measures that would help resolve the issues currently haunting the PhilHealth. This issue on the table is not going to be simple and short, as there may be many propositions on how to reshape or reorganize the country's state health insurer in the face of the numerous controversies hounding the agency. But the committee is confident that this measure will be worth our time, as it provides an interesting takeoff in the proactive and innovative discussion of appropriate policy direction or response to address the current organizational challenges besetting PhilHealth. Before we proceed, allow me to make an account of the Committee on Health's accomplishment as of December 15 last year. Do not, however, construe this as sort of a curtain call, because we are not yet done for this Congress. But for the information of everyone, from the opening of the 18th Congress until December 15, 2021, a total of 1,014 measures were primarily referred to the Committee on Health. Of these, 884 are House bills, 126 are House resolutions, and 4 are House joint resolutions. 64 other measures were secondarily referred to the committee, 52 of which are House bills and 12 are House resolutions. Out of these measures, the committee was able to produce one Republic Act of national significance, which is Republic Act 11463, also known as the Malasakit Centers Act. A total of 28 bills of local significance were also enacted into law from the start of 18th Congress until December 15, 2021. Significantly, a total of 124 bills of national significance were approved and transmitted to the Senate, which we hope will be treated with the same utmost urgency and passion by our counterparts in the upper and smaller chamber, as we did here in this committee and the House of Representatives. We stand on the exigency of these national measures, many of which are measures that address not only the ongoing pandemic, but other public health emergencies that may arise in the future. The very reason why these bills were given much thought, seriousness, and determination on this part of legislative spectrum. May I therefore ask our honorable senators to consider these bills, which among many others include the following urgent measures, like House Bill 6496, which is the strengthening of the national program for the elimination of tuberculosis, amending for the purpose RA 10767, or the Comprehensive Tuberculosis Elimination Plan Act, House Bill 6497, modernizing the regulation of health facilities and services. House Bill 8558 or Mandatory Immunization Program. House Bill 8999, Instituting Medical Reserve Corps. House Bill 9561, establishing the Philippine Health Security Council. House Bill 9456, stockpiling of strategic and critical drugs and medicines, vaccines, devices, and materials for public health emergencies. House Bill 9560, Modernization of Public Health Emergency Preparedness and Response Capabilities, establishing for this purpose the Center for Disease Prevention and Control. House Bill 9559, Philippine Virology Science and Technology Institute, and House Bill 10245, Philippine Electronic Health or eHealth System and Services in support of the UHC or Universal Healthcare. 78 bills equivalent to 70 substitute bills of local significance were approved on third reading and transmitted to the Senate. So on behalf of the authors and co-authors of these measures, I am asking the Senate to act on them with haste. On top of this, one local bill was approved on second reading as of December 2021. One national bill is under second reading, which is the Overseas Filipino Workers Hospital, and 49 bills of national significance classified into 12 subjects were approved at the committee level. Some of these are awaiting approval by the Committee on Appropriations, while some have draft substitute bills already for further discussion and refinements with concerned national government agencies and major stakeholders. These are the following. 2 bills provide for the establishment of apex and end referral hospitals in all DOH retained hospitals. 8 bills provide for the establishment of the National Geriatric Care Center and Research Institute and Regional Geriatric Specialty Cares in all DOH retained hospitals. 5 bills provide for continuing COVID-19 benefits for public and private health workers and barangay health workers. And 5 bills provide for a progressive elimination of industrial trans fatty acids in the Philippines. 9 bills provide for the establishment of an emergency medical services system in support of the UHC. And 10 bills provide for national oral healthcare program. 3 bills provide for the prevention of counterfeit pharmaceutical products. And 1 bill provides for the establishment of National Patient Navigation and Referral System. 3 bills provide for the mandatory administration of COVID-19 vaccines. 2 bills provide for the strengthening of the traditional complementary medicine system. And 1 bill provides for the institutionalization of the National Psoriasis Care Program. Earlier, I quoted Senator Ted Kennedy in part, and let me now complete what he said. After a brief narrative of what had been the long list of the accomplishments of this committee, and this is what I hope to do until the last minute of the 18th Congress and even beyond. And he said, the work goes on, the cause endures, the hope still lives, and dreams shall never die. Nagpapasalamat po ako sa lahat ng bumubuo ng membership ng Committee on Health mula sa majority and minority groups at sa ating secretariat sa kanilang pakikiisa upang magawa natin ang mahabang listahan ng mga batas at panukala na ating dininig, pinag-aralan, pinasa matapos ang mahabang panahon ng pag-uusap. Gayun din po ay nagpapasalamat tayo sa lahat ng ating mga naging resource persons at mga walang sawang naging kasama mula sa umpisa hanggang sa katupusan sa liderato ng Department of Health sa panguna ni Secretary Francisco Duque III, ng PhilHealth sa panguna ni Attorney Geran, ang ating hospital and professional groups and non-government organization. Sa inyo pong lahat, maraming salamat po. Would like to recognize now also the presence of the following members. We have Representative Stella Luz Quimbo, Representative King Swansing, Representative Hector Sanchez, Representative Franz Castro, and Representative Tof de Venecia. We'll now hear from the PhilHealth on the updates based on the previous discussion. Attorney Garan, we hear updates on the issues that we discussed from previous hearings. Attorney Garan, you are now recognized. You have the floor, sir. Wala po kayong audio, Attorney Garan. PhilHealth, can you fix the audio? Attorney Garan, you have the floor. Okay, while waiting for PhilHealth, I think we have representatives from Private Hospitals Association. Do we have the president, Ma'am Sylvia? Do we have the president or any representative from Private Hospitals Association or Philippine Hospital Association?
Ma'am, wala po po. Pero we have from ARTA. Hello, ma'am.
Yeah, but we want to hear first sana from PHA or PHAPI. So wala tayong guest, anyone?
I'll follow up, ma'am. Apo. We'll follow up, ma'am. Okay.
Hello. Mahina po.
Ano ba yan?
Ay na po tayo, Attorney Garan.
Hello? Can you hear
Yes,
us, ma'am?
Yes, sir. Loud
Can
and
you hear us,
clear.
ma'am?
Yes, sir.
Thank you. Thank you. Good morning, Madam Congresswoman Helen Tan, Honorable at that. And of course, the Honorable Stella Luz Quimbo. And the rest of the members of the committee present right now. And even those in their homes on Zoom. And lahat po na nakikinig dyan. Members of the House Committee on Health, distinguished representatives, all other participants, to my PhilHealth family. And of course, yung boss namin sa Department of Health, ladies and gentlemen, a pleasant morning to all of us. I will be addressing 2 points here. One is on the so-called claims processing, and the other one is the act to address the social health insurance crisis and for other purpose, authored by Madam Stella Luz Quimbo. Addressing
Attorney
the so-called
Garan, Attorney, we'll focus first on the updates on the policies from previous hearings. Ang bill po ni Kong Stella will discuss after po nung ating mga updates. Pag-usapan po muna natin yung usapan last hearing regarding po doon sa mga previous circulars. Ano na po yung actions undertaken ng PhilHealth regarding po doon sa mga issues na diniscuss po natin, like for example on updates on your TSPC policy, updates on the claims on the probable intermediate packages, the DCPM, ano po yung updates ninyo, and other updates from PhilHealth po, yung mga recent policies that you are instituting.
Okay, thank you, Madam Helen Tan. And sorry kanina po sa glitch po sa aming systems dito. Unwavering in our mandate of ensuring every Filipino has access to the full spectrum of essential quality health services, PhilHealth has unceasingly come in aid of its members through steadfast payment of benefit claims. As of January 7, 2022, PhilHealth has released 12.05 billion to 444 hospitals through the debit credit payment method. The DCPM is an accelerated payment method intended to afford hospitals sufficient cash flow to continue providing the sick with quality health care during the pandemic. Through the DCPM, hospital funds are augmented to enable them to increase their capacity in managing more COVID patients. Further, our constant dialogues and coordination with hospitals have been productive, and talks are continuing to reconcile our claims data. Much also has been clarified regarding discrepancies and requirements that our partner facilities should address in order to be reimbursed on time. Your Honors, the PhilHealth receives an average of 1 million claims a month. In 2021 alone, the average received claims increased by 25%. The 60-day limit is particularly necessary as it gives the corporation time to weed out non-compliant submissions from the good ones. Pay to pass, and the corporation shall be accused of paying recklessly. Pay to slow, and PhilHealth will be blamed for not doing its job. May also add that since 2007, there has been no significant increase in PhilHealth's human resource complement. This, coupled with the ongoing pandemic, made the task of claims processing hard. Faulty documentation of claims that results to denial and return to hospitals of claims is another issue that hamper the prompt payment of claims to our providers. In accordance with our mandate to protect our members' funds, we have to scrutinize every claim and pay only those that are in order. With respect to other details, Madam Chairwoman Helen Tan, the other details will be in the report of Attorney Eli Dino Santos. Thank you po.
Thank you, Attorney. Attorney Santos. Attorney Santos.
May I proceed, Madam Chairperson?
Yes,
Helen Tan?
please proceed po.
Good morning, Madam Chairperson Helen Tan. Good morning to all the members of the present committee, the Committee on Health, all who are present here today. Good morning. Madam Chairperson, we have a presentation on the PhilHealth claim status. May I request that the slides be flashed on the screen. May I proceed, Madam Chairperson?
Yes, Attorney Santos, you have the floor.
So this is a presentation of the PhilHealth claim status. Next slide, please. So this slide shows the count, amount, and percentage of all received refiled claims, paid and in process, COVID and non-COVID for hospitals per year from 2020 to 2022. This only covers level 1, 2, 3 hospitals and infirmary. The slide shows that in 2020, we received a total of 9.3 million claims. This is claims count. And 6% of this are COVID claims. That is 515,000 COVID claims. And the amount we paid in total for 2020 is 81.97 billion pesos. And for COVID, we paid 3.7 billion pesos. Now we go to the year 2021. So the total number of claims we received for 2021 is 11.19 million number of claims. 33% of these are COVID claims or COVID-related claims, which is 3.746 million number of claims. So the total amount paid for 2021 is 64.58 billion pesos. And the total amount paid for COVID claims is 14.94 billion pesos. We will notice that the in-process claims, we have 2.6 million in number of claims in the amount of 53.17 billion pesos. The following slides will address this in process. Please take note that the total received here will likewise be reflected in the next slide. So this slide shows the RTH and denied claims. The same for hospitals from year 2020 to 2022. So for the information of our chair, Madam Chair Helen and the members of the committee, PhilHealth receives an average of 5% RTH per year and as well as 5% denied. This is based on the data of the previous years. So under RTH, for all the claims, the rate of RTH is 4%. For non-COVID, we can see that the RTH for total is 2%. So this is within or similar to the previous years. However, if we can notice, the RTH for COVID-19 is 24%. This is higher than the non-COVID. And for the denied claims, again, throughout the years, we have an average of 5% of the claims denied. So under 2020, the 4% denied is still within the average of PhilHealth throughout the years. However, if you notice, 11% under COVID are denied. So in total, 5% is still within the average of denied claims throughout the years. In 2021, for non-COVID, we have RTH of 5%. Again, still within the average. However, under COVID-19, we have a 13% RTH. All in all, 8%, slightly higher than the average rate through the previous years. And for denied, still within the average. However, the denied for COVID is slightly higher, which is 6%. So the next slide will show the total for claim status for hospitals from 2020 to 2022. So if we,
Madam
so this
Chair,
slide,
Madam Chair.
Ongying,
Yes, Madam Chair.
Juan Santos.
Yes, can we avoid using acronym? Like for example, RTH, hindi ko po naintindihan what is RTH.
Attorney Santos,
I apologize.
return to hospital, complete mo yung wag abbreviation lang.
I apologize, Madam Chairperson. So RTH means return to hospital. So these are claims that have deficiencies. These are returned to hospital for compliance. And when they are returned to PhilHealth, they will again undergo the usual processing of claims. So this slide shows the count, amount, and percentage of all received refiled claims, paid and in process, for COVID and non-COVID for hospitals during the pandemic years in total. So this is a total for 2020 until January 6 of 2022. So what is remarkable here is the 57.3 billion in process. However, the succeeding slides will show how PhilHealth will address this. So if we check on the RTH, that is, return to hospital claims, that is 6%, again, slightly higher than the average 5% of RTH throughout the years. And the total denied is 4%. This is still within the average of the denied claims throughout the years. Next slide, please. So this slide will show the aging of in-process claims, count and amount, again from January 2020 to January 6, 2022. So the total in process is 57.3 billion pesos, and the within 60 days of this is 23.98 billion pesos, and the beyond 60 days is 33.32 billion pesos. The succeeding slide will address the beyond 60 days in process. Next slide, please. So this slide will show the in-process claims due for payment or beyond 60 days. So from the 33.32 billion pesos of in-process beyond 60 days, we deduct the 7.87 billion. The reason is that we have already already paid this through the DCPM. So what is due for payment is 25.45 billion pesos. Next slide, please. So this graph shows how PhilHealth will address the remaining 25.45 billion due for payment. 66% of this is being addressed and will be addressed by DCPM 3, which is being implemented right now. The total amount of DCPM 3 or nationwide DCPM is 17 billion pesos. 28% of this is addressed by the DCPM.
Paki-complete mo yung DCPM.
Madam Chair, the DCPM is debit credit payment method. This is a strategy implemented by PhilHealth initially when there was a surge in the NCR area, and then it was expanded to other areas which were declared as under ECQ and MECQ, and later on, because of the recommendation of the IATF and ARTA, we expanded to a DCPM debit credit payment method for nationwide application, and this is being implemented right now. At present, we are still on the third week or fourth week of implementation of the debit credit payment method nationwide. So the remaining 1.45 billion will be addressed by the debit credit payment method 4. This is still being studied. This will cover the in-process claims starting August 22, 2021 until the present. So this is still being studied. An initial study had already been presented to the executive committee, and the recommendation is to study it further and present the same to the board before its implementation. So once we have addressed all these claims, the remaining will be those that are already current. Next slide, please. Next slide, please. Thank you. So this is the debit credit payment method statistics as of January 7, 2022. Again, the debit credit payment method 1 was implemented because there was a surge in the NCR, and this was expanded. And the total amount released for both DCPM 1 was 6.8 billion. And then we expanded to DCPM 2 because there was a declaration of ECQ and MECQ outside of NCR. So we, under this debit credit payment method 2, we paid 4.3 billion pesos. And now the debit credit payment method 3 or nationwide application is still on its third or fourth week of implementation. So far, we have released to 65 healthcare providers a total of 1.09 billion pesos for a total of 12.06 billion pesos. Next slide, please. So this report will show the pandemic claims for COVID. So this slide shows the count and percentage of received, refiled COVID and COVID-related claims and total amount paid by status to all facilities from January 2020 to January 6, 2022. So the total amount, the total number of claims received is 7.54 million number of claims, and the total amount paid for all COVID and COVID-related claims is 28.6 billion pesos. It is worthy to note that under the testing covers 94.79% of all these COVID and COVID-related claims, which is 7.13 million number of claims, a total of, in amount, a total of 14.765 billion pesos. Next slide, please. That's all, Madam Chair. Madam Chairperson Helen Tan, honorable members of this committee, thank you very much for this opportunity. Good morning.
Hey, Santos. Attorney. Pakibalik nga nung last slide. Attorney Santos, meron lang po akong question.
Last slide.
Yung last slide po. So in this slide, you're showing na on COVID-related claims, you were able to pay 65% of all filed claims. Am I right?
That's correct, Madam Chair.
That's for isolation, inpatient, and inclusive of testing.
That's correct, Madam Chairperson.
Okay. Which means 35% yung due for payment ninyo.
Madam Chairperson, if I may.
Mm-mm.
Madam Chairperson, the in-process claims, meaning the claims that is still with us, that is being processed, is
22%.
22%, while the RTH is 9%, and the denied, the return to hospital, COVID and non-COVID claims, non-COVID and COVID-related claims is 9%, and the denied is 5%. And these comprise the whole 35%, Madam Chairperson.
Thank you, Attorney Santos. So my question is, there seems to be an improvement on the payments that given to the hospitals. But ano po ang primary reason ng mga hospitals for disengagement or non-renewal of accreditation is delays on payment, no? Unfortunately, wala tayong guests from Philippine Hospital Association and Private Hospital Association of the Philippines. Wala tayong representative. So, doon sa presentation mo, Dr. Almora, you're here. Thank you, sir. Thank you for joining. So, as early as December, meron nang nag-announce na they will not renew their accreditation. How do you reconcile yung data ninyo ng PhilHealth with the data of the hospital groups? Attorney Santos. Kasi ito presentation nyo based doon sa inyong data. Pero must be merong discrepancies on the actual data na meron naman ang ating mga hospital groups. Paano po kayo nagre-reconcile?
Madam Chairperson, if I may, Attorney Santos.
Go ahead po.
Madam Chairperson, we were directed and ordered by our President and CEO, Dan Tegeran, to continuously coordinate with hospitals. If there is a need to do it on a daily basis and a one claim basis, we will do it, and we are actually doing it. Madam Chair, we are continuously reconciling with our hospitals. The President and CEO released an order to all our regional vice presidents, all our branches, to continuously reconcile and engage with our healthcare providers. And since Dr. Almora is here, Madam Chairperson, I'm sure he will attest to this. Thank you very much, Madam Chair, honorable members of this committee.
Thank you, Attorney Santos. Dr. Almora?
Yes, Madam Chair. Good morning.
Yes. Ano pong updates with the hospitals? Kasi last December, mayroong mga nag-announce like FEU hospitals announced na hindi sila mag-renew ng accreditation with PhilHealth. Although in-extend ang PhilHealth up to January 31, am I right, Attorney Geran? Up to January 31 ba ang application of the renewal?
Madam Chair, if I may, Attorney Santos.
Yes, yes.
Madam Chair, the reason there is an extension is because of the usual delay in the issuance of the license to operate from DOH. We know the challenges being experienced by the regulatory agency, Madam Chair. So likewise, PhilHealth adjusts to this. So we extended the period for the submission of the renewal of accreditation of our partner healthcare providers, Madam Chairperson. Honorable members.
Thank you, Attorney Santos. Dr. Almora, currently po, meron na ang mga hospitals na mag-disengage ng accreditation based on the information you have.
Yes po. May mga hospital with the intention to disengage. It's not the decision of the Philippine Hospital Association. However, we gave them the right to decide for themselves if they are going to disengage based on their problems that they are encountering with PhilHealth.
And the number one reason is due to unpaid claims.
Oh, yes, Madam Chair. And the other issues, Madam Chair, such as denied claims, the arbitrary denial of claims, and in some cases, it's the lack of due process in the procedures and rules on administrative cases for those hospitals with administrative cases.
Okay, thank you. Ang Iloilo hospitals expressed or announced that they will disengage with PhilHealth. Do you confirm that, Dr. Almora?
Madam Chair?
Iloilo hospitals.
Yes, there are I think 7 hospitals private hospitals in Iloilo, Madam Chair.
Okay. And the FEU hospital, sir, natuloy sila na mag-disengage din sila?
I have no update, Madam Chair, but I know that PhilHealth is reaching out to them, and they are in the process of negotiating, Madam Chair.
Okay, thank you. So I have a question for PhilHealth since you discussed on the debit credit payment method. May I know how did you come up with DCPM and why do you think it is the best compromise you could offer to hospitals? Attorney Santos.
Madam Chair, thank you for that, Madam Chair. Madam Chairperson, personally, Madam Chairperson, I have observed what is somehow the problem that is hounding PhilHealth. And this caused the delay in the payment of claims. 3 general reasons, Madam Chairperson, honorable members of this committee. One is personnel, Madam Chairperson. Our number of personnel is still maintained at the present number since 2007. However, the number of claims kept on increasing every year. This year, Madam Chair, last year, for 2021, it increased to approximately 27%. And the personnel has not increased. It even decreased because of the challenges experienced by our employees when at the onset of the pandemic. Another factor, Madam Chair, are the policies. We know this for a fact because we have been discussing this in several hearings, Madam Chair, in several meetings with our partner providers, even with the Philippine Hospital Association and the Private Hospital Association. But PhilHealth is addressing these issues in policies. We are continuously adjusting. Another factor, Madam Chairperson, is our IT system. Admittedly, our IT system has a problem. We have admitted that several times in several meetings. However, the answer to this problem in IT system will not happen. Or to address this, it will take time, Madam Chairperson, honorable members of this committee. So the management of PhilHealth devised or crafted through the leadership of President and CEO Dante Garan this debit credit payment method that will pay the in-process claims, meaning it will pay immediately the in-process claims that are already in PhilHealth and computed based on the data with PhilHealth. With this, Madam Chair, we were able to respond to the surge in NCR as well as other places in the Philippines. And now we are already implementing it nationwide, Madam Chairperson, honorable members of this committee. So the debit credit payment method is based on the in-process claims, which are already in the hands of PhilHealth. Madam Chair, honorable members of this committee, thank you.
Thank you, Attorney Santos. Dr. Almora,
Yes, Madam Chair.
narinig ko hindi yung DCPM hindi siya acceptable compromise to some of the hospital. What could be the reason?
Yes, Madam Chair. Until now, the hospitals are being baffled, they're questioning why they have to apply for DCPM when the non-COVID cases are being processed through the regular process. So many of them would like their claims to be processed the regular processing of claims. And if we can see the plan in the pie diagram as presented, all the unpaid claims are going to be paid through DCPM, but some of the hospitals have not applied because you need to apply for the DCPM. As far as some of the hospitals are concerned, this is in violation of the ARTA law for being asked to give additional requirement for the payment of their claims. So that is the problem, Madam Chair. Many are waiting for the payment through the regular process. But of course, if I may be allowed to give a little background of how things happen, Madam Chair.
Go ahead.
Our problem started really when during the investigation of the alleged procurement anomalies, the matter of IRM cropped up. This is the interim reimbursement mechanism. This is a process of advance payment for services considering the presence of a calamity or disaster. And that IRM was intended to give the hospitals fund to prepare for the expected COVID outbreak. And indeed, it was good because those hospitals that received were able to prepare for their triads, to improve their facilities, to do some structural changes in the hospital to prepare for the COVID. Unfortunately, during the hearings here in Congress and in Senate, it was disallowed. The IRM was disallowed. So the PhilHealth immediately was at a loss how to reimburse the hospitals. And if we are to go through the regular process, I understand that really the hospital personnel were one of those that were the PhilHealth personnel were one of those that were prevented from traveling to the offices. So there was really a problem in the payment. But so we waited. We know, we are aware of the problems of PhilHealth like any other offices. We waited until 2021, April 2021, when we noticed that no payment for COVID claims are being made already. Not a single claim was being paid. So we wrote a letter to PhilHealth, and we did have a dialogue. And the immediate response was to create the accounts reconciliation office in the regional offices. So there were attempts to do. Initially, there was difficulty of accounts reconciliation because they were looking at different datas, and so it was considered as a failure initially, the accounts reconciliation. And succeeding dialogue with PhilHealth, we came up with the DCPM, which is the Debit Credit Payment Mechanism. But the undertakings that has to be taken by the hospital, they have to made to sign that they're going to reimburse, and that the hospital director will be made responsible for the repayment, something like that. And they were skeptical, Madam Chair. They were suspicious that something is wrong, and they do not want to go to something that is vague and probably endangering themselves. So there was reluctance on the part of hospital management to apply for a DCPM. There was improvement though as we went on, and there is more and more hospital applied for DCPM, and there was improvement in the payment of COVID claims. However, there are still hospitals that are skeptical because they cannot understand why we are talking of DCPM when we can talk about the normal processing, is speeding up the normal claims processing. So that is the main problem, Madam Chair. However, we would like to express appreciation also to PhilHealth for trying their best. But I know that there are other problems other than what was mentioned that is keeping them from doing the normal processing of claims. You have to remember that there are personnel of PhilHealth in hospitals in Cebu that were sued for the payment of probable claims, which is actually allowed. And there were also in Region 1 personnel of PhilHealth and hospitals that were sued for the IRM. So we believe that one of the reasons is the fear of the regional offices personnel to process claim for fear that they will be sued for one reason or another if they will process the COVID claims. Because indeed, there are many vague and confusing and unfair provisions in the circulars that came out regarding the COVID management, Madam Chair.
Thank you, Dr. Almora. Speaking of that probable claims, that you mentioned na naging reason kung bakit marami sa mga claims natin ay denied because of that case in Cebu na meron na I think napila ng kaso and yung mga recipients ng IRM. May I ask PhilHealth kung meron na kayong policy clarifying that probable claims, no? Attorney Garan.
Thank you, Madam Helen Tan. Can we please recognize Dr. Clemen Bautista to answer the question, Madam?
Okay. Dr. Bautista. Dr. Bautista.
Good morning, Madam Chair.
Yes, medyo mahina yung audio mo. So na-mention ni Dr. Almora yung cases natin doon sa Cebu and some regions wherein some of the personnel ng PhilHealth and hospitals were sued, no, because of that payment. Meron na ba tayong clarification doon sa policy? Kasi as far as I remember in several hearings natin, yan yung isa na recommendation natin for you to clarify in the succeeding circulars.
Madam Chair,
Yes.
we have ongoing policy revision of the COVID-19. And that we will be including here the clarification on the definition of the probable and how to consider eligibility to the COVID claims. There were policy statements in the previous circular 009 2020 that actually points to considering claims for COVID-19 package based on the clinical management or such that the COVID claims provided to us would show that these patients have been managed clinically as a COVID. In that case, we should pay them as a COVID claim. Yun po, and that they should be considered as probable cases.
Dr. Clement, meron kayo advisory number 2022-001 on PhilHealth's coverage of probable COVID-19 pneumonia cases under COVID-19 inpatient benefit packages and the no co-payment policy. So, meron kayo ditong clarification, ibinigay nyo that PhilHealth has extended coverage of probable COVID-19 pneumonia cases with inpatient COVID-19 benefit packages admitted from November 26, 2020 to June 18, 2021. So, which means from the time na issue nyo yung circular stating or allowing that probable benefit package, I can't recall ko ano yung starting nung month na yun but I think that was 2021 early or first quarter. So up to June 18, 2021, right?
Yes, Madam Chair.
Ang question, ang marami sa mga claims ng probable hindi binabayaran because of what happened doon sa kaso na pinailan ng NBI in Cebu, wherein they paid the probable COVID claims.
Yes, Madam Chair. If I may,
Dr. Clement, is this advisory enough for the regional vice presidents na magbayad na doon sa mga pending claims under probable package? Ito
Yes,
pong advisory nyo, advisory number 2022-001. Enough na po ito para yung mga RVPs natin ay magbayad?
Madam Chair, the existing circular actually provides that they can pay based on the case definition and that patients are managed clinically as COVID case. But then it seems that they have confusion pa rin or that they were not they had a problems or madam, when it was questioned that their decision was already questioned by a certain case filed in Pro 7. So therefore, they then had problems or dilemma in paying this, even though they were already oriented that they can pay claims based on the critical management and as claimed by the providers. So
I think, Dr. Clement, parang paulit-ulit natin pinag-uusapan itong problema na to. Pero until now, hindi pa rin ninyo parang straightforward, no? Na kina-clarify. Number one, yung definition ng probable claims, no? Supposed to be dapat manggaling sa head office sa inyo yung clarification. Kasi lahat ng mga regional vice presidents, ang naririnig ko na feedback from mga hospital owners, ang nire-reason nila is that they are seeking or they sought clarification from the office of the president, of the CEO on that. And that's the reason why bakit hindi pa nila mabayadan yung bulk of the claims under this circular, no? So, yung advisory, simple lang, ang tanong ko, kung enough siya for them to pay. Yes or no lang po ang sagot. Kasi napakalinaw po doon na in-extend ninyo from the time na nilabas nyo po yung circular up to June 2021, ay pwedeng i-file po yun at bayadan na ng PhilHealth. Of course, in compliance doon sa guidelines, existing guidelines na meron kayo. So yes or no lang po ang tinatanong ko.
Madam Chair, if I may
Attorney?
Madam Chair.
Yes po, Attorney Garan, sino po?
Attorney Santos, Madam Chair, if I may.
Attorney Santos.
Thank you very much, Madam Chair. Madam Chairperson, the usual process is that the regional offices will approve the payment for these claims. And we know the issue, Madam Chairperson. In fact, yesterday, Madam Chairperson, the PCEO, the Antegeran, called for a meeting with the regional offices, with the RBPs, as well as the medical evaluators in area 1 and 2. So, Madam Chair, there were several inputs from our regional vice presidents as well as our branch managers. In fact, Madam Chair, we committed to issue a directive, an order from the office of the COO just to clarify and direct the regional offices what to do with respect to this probable COVID. So some recommended that this OCOO memorandum is sufficient. But there were also several regional vice presidents who requested and proposed that a new policy must be issued, crafted by the central office. So on our part, the management part, we are ready to issue a memorandum to clarify the issues regarding this probable case, Madam Chairperson. However, there were also, again, a recommendation and proposal that instead of the memorandum, why not change the policy? And that's what the HFPS is undergoing right now, Madam Chairperson, honorable members of this committee.
Attorney Santos, if you can furnish us the copy of that memo of the COO to the RVPs. And please lang, pakisagot lang po. Ang problema, again, babalikan ko, yung definition yon ng probable cases, no, is different from 2021-009. Okay? Inadapt niyo po yung definition naman ng DOH that gives the RVPs or the regional offices confusion in the implementation. Kasi magkaiba po yung definition. So which ang susundin nila. So from the time, dapat po, nung naglabas kayo ng circular ng 2021-009, hanggang kailan yung validity noong definition na yon? Kung hanggang June 2021 ba yan? Or ano yung recent advisory ninyo? I mean, 2020 yung sinasabi ko na circular-009. So paki-clarify, I think yun yung confusion ng mga regional offices, Attorney Santos. Pabalik-balik po tayo dito, pero it seems that nasa taas ang policy making body. You have the board of directors as a policy making body. Paki-review niyo po yung definition. Yun ang nagkakaroon ng reason bakit merong non-payments or delays of payment because of that confusion. And takot yung mga empleyado ninyo na magbayad because nga of that precedent cases filed against their colleagues. So, Attorney Santos will ask for the complete at least minutes of what transpired on that meeting held yesterday, and then yung memo sent by the COO to all RVPs, and then clarification po again on your first advisory. Yung gusto kong sagot po yung yes or no, does it suffice na for them to pay? Okay, I think Dr. Degrano is raising his hand from private hospitals. Then we'll call Kongging.
Madam Chair, may I interject?
Yes, Kongging.
Yes, Madam Chair, thank you. Can we, ano pong problema? Bakit hindi natin nakikita mga taga PhilHealth? Is it because of the internet connection? Kasi tayo, Madam Chair, parang ang hirap-hirap makipag-usap sa hindi mo nakikita yung mukha.
Record nga po yung videos nyo, parang hindi lang yata yung IT infrastructure nyo may problema, pati internet connection.
Kasi,
paano naman tayo mag-efficient?
Yes, maaga po tayo nagising, nag-make up pa tayo, Madam Chair, nag-dress up pa tayo, we are prepared. Tapos ngayon yung kausap natin, di natin makita, Madam Chair. So parang hirap naman nun.
Attorney Santos, can you turn on your video to all PhilHealth officials? Paki-turn on po ng videos ninyo. Dr. Degrano from Private Hospital, I think he's raising his hand.
Yes po. Good morning po, Madam Chair. At saka
Thank you for joining, sir.
Sorry na late ako. But then anyway, sasagutin ko lang po yung question kanina na regarding dun sa mga private hospitals na nag-signify dati na mag-disengage, like FEU. I think they were able to talk with PhilHealth already. So medyo dinifer nila yung kanilang disengagement. At the same yung pong 7 hospitals from Iloilo also were able to talk with the management of PhilHealth, and they made some discussions and negotiations. And so until end of January po, they are waiting dun sa mga resolution ng kanilang mga hinihinging dun sa kanilang statement. So with that, after po noon, then we will see kung paano ang magiging response din ng PhilHealth. And we are also be having a meeting with the top management, the Private Hospital Association, with top management of PhilHealth anytime siguro within the month to trace out all of these things na nagiging problema po natin. Yun lang po, Madam Chair.
Thank you, Dr. Degrano. Tapusin ko lang po yung question ko, before I call on our members who wishes to ask question. Since we have COA, I've decided to invite COA kasi ayaw natin ng after the implementation of a program, there will this controversies that will arise like what happened in IRM, no? May I ask COA if DCPM is compliant with auditing rules? COA? Any COA representative? Ma'am Sylvia, sinong natin, guest from COA?
As of now po, wala pa rin po, ma'am, but we invited them.
Fine.
Okay, yes, ma'am.
Anyway, can we follow up? Kasi importante sana na masagot
Yes,
nila yung tanong natin. Okay, I think we have yung COA po kasi we heard na meron silang recommendations na mag-pre-audit before payment. Tama ba ako, Attorney Garan? COA recommended PhilHealth to conduct pre-audit before processing of claims.
Thank you, Madam Helen Tan. You were asking, COA is supposed to answer question about the DCPM is legitimate, no? Or it's within the rules, no? Since COA is not around, but in the several meetings that we made with COA, it does not only appear to us, but we are very certain that the DCPM, the debit credit payment method, is acceptable because number one, what is being paid in the DCPM is an in process that is already in the records of the PhilHealth, and these are legitimate obligations, liabilities. The only concern of the COA is to make some kind of what we call this safety nets, so that the funds of the National Health Insurance Program would not be compromised, and that is very much our concern. And with respect to some safety nets like what we call this pre-medical evaluation, usual medical evaluation and claims processing has been observed, Madam Chair. So I would like to state that the DCPM is good. It is a payment that is fast, because we know our partners, the healthcare institutions, are in need of cash, just like other businesses now being ravaged by this COVID pandemic. So, yan na po. Thank you.
Thank you, Attorney Garan, but I still want to hear it direct from COA, no? Na it's within the auditing rules natin. Anyway, sir, are you aware of the provision on the global payment or global budget under the UHC?
Yes, Madam Chair, I read about that. I heard about that. But honestly, I am not yet prepared to discuss that.
Okay, so I guess that's one option that the PhilHealth can take a look into and decide on ano na yung payment method that we're going to use instead of the DCPM. We're in selective kasi ang inyong DCPM is for COVID-related claims only, no? So for consideration siguro po ng PhilHealth, at least mapag-aralan for implementation under UHC law. May I call on...
Madam Chair, if you please, I would like to state that the DCPM is not only for COVID, but all cases within the given scope, within the given period of time, where at least a healthcare institution has one COVID case. Yun po. Lahat, hindi lang COVID po. At I would like to comment doon sa statement ni Dr. Almora na salamat po for that very gentleman remark, including Dr. Digrano, na maganda po ang sinabi naman sa amin. And sa totoo lang po, kasi ang kinumplain talaga noon na ni Dr. Almora was the slow payment, very slow payment sa COVID. Pero ito po, nagawa natin po ng paraan. Sa totoo lang po, statistics will bear us out. In 2020, ang nabayaran na po namin sa COVID is something only like 3.1 billion, Madam Chair. Pero in 2021 po, ang nabayaran po namin sa COVID ay 14.9 billion or a very marked improvement of something like 11.72. Thank you po. At saka isa po doon po sa mga ginawa po namin na estratehiya po doon sa gustong nag-threaten na mag-aklas or what we call this would disengage in their accreditation with the PhilHealth. Nakausap po namin talaga ang yung tinatawag namin na 7 hospital sa Iloilo po. Ang gusto na po nila po makausap ang taga PhilHealth eh. Yun ang gusto na po nila. So magkano man lang yung hindi naman sobrang laki yung utang namin, no? Naremedyohan po yun. There were commitments made. There were even specific persons tasked to do the face-to-face reconciliation on the books maintained by the PhilHealth and that of the individual healthcare institutions. And yun po, pati time frame na po namin na sinabi doon na within 90 days, no? Within 90 days, bayaran namin yung ganong kalaking utang. And of course, we have to show something that is also concrete para naman sila maniwala. So within within January 31 of this year, hopefully we will be able to deliver the deliverable within us, and that is pwede po namin ma-deliver. Salamat po.
Thank you, Attorney. I would like to call on Kong Stella Quimbo. If you have some question on the matter.
Yes, Madam Chair. Of course, Happy New Year muna sa lahat. Madam Chair, my first question is for PhilHealth. You showed some slides on the aging of claims, pero dalawang pieces of information lang ang nakabanggit doon, which is number of claims below 60 days and then number of claims beyond 60 days. Pero maaari ba naming malaman, ano ba talagang average number of days from the time you receive the claim up to the time that you pay? Kasi pag titignan din natin yung huling slide, which is on COVID claims, from January 1, 2021 up to January 6, 2022, doon lamang sa inpatient COVID cases, 21% lang ang nabayaran. So that's 12 months. That's so 360 days, right? So ano talaga? Ano yung average number of days ng processing? Pag sinabi nyo kasing 60 days, beyond 60 days, pwedeng 61, pwede rin 300, pwedeng 320. So ano ba talaga?
Madam Stella, can I respectfully refer to Attorney Santos to clarify matters? Thank you.
Attorney Santos.
Madam Chairperson, Honorable Representative Quimbo, based on the data at hand, from January to November 2021, our turnaround time of good claims is 43 days, Madam Chairperson.
No, that's only for the good. Ang hinahanap natin yung para sa lahat. So yung sinasabi mo sa akin is yung na-process ninyo, yung success. But that's not what I want. I want is yung sa kabuuan, sa lahat ng claims, tignan nyo to, yung inpatient, 21%. Hindi, mali pala ako, hindi lang pala 12 months. This is 24 months kasi January 2020 up to January 6, 2022. So in a span of 2 years, 21% lang ng inpatient ang bayad. So ano ngayon ang average number of months para sa lahat ng claims? Wag lang yung successful. Ang binibigay mo sa akin na 40 days is only for yung successfully paid. Tingnan mo yung kabuuan, lahat ng claims, yung successful at saka yung failed. Ano yung average number?
Madam Chairperson. If I may.
Yes, go ahead.
Madam Chairperson, Honorable Stella Luz Quimbo. As of the present moment, we do not have that data, but I have already requested.
That's unacceptable. That is completely unacceptable. We have had many hearings on this. That is completely unacceptable. Hindi po ba kayo nahihiya? Napupunta po kayo dito sa Congress. Klarong-klaro po ang paksa ng ating pag-uusapan sa araw na to, which is unpaid claims. Hindi nyo ba na-anticipate? Natatanungin namin yan. Hindi nyo ba na-anticipate na we will find it kulang yung sinasabi ninyo na number of claims less than 60 days, number of claims beyond 60 days. Ang haba nun, yung beyond 60 days can mean so many things. Pwedeng 500 days nga yun eh. So, kasi gusto po namin intindihin kung saan humuhugot private hospitals. Malaking problema kapag mag-disengage lahat ng hospitals. Ano ibig sabihin nun? Kailangan pumunta ang tao na walang pambayad sa hospital, sa public hospital lang, na hindi kakayanin ng ating public hospital system. Sa ngayon na nga lang both public and private hospitals, hindi na nga kakayanin ng COVID patients. Kapag mag-disengage pa ang private hospitals, paano na tayo ngayon as a country? So that is completely unacceptable. I think that you know it. The fact that you have all of these numbers in an Excel file, it's impossible that you don't know it.
Attorney Santos.
Madam Chairperson, if I may.
Yes.
Madam Chairperson, as presented by Dr. Art Alcantara, our turnaround time for all claims is 62 days. Madam Chairperson, for
So, okay, we're not understanding each other kasi meron kayong slide, paki-show ulit, yung naka-indicate 51% are beyond 60 days. So 49% below 60 days. So gusto natin malaman, pag kinuha mo na lahat ng claims, ano yung average number of days from start to end? Kasi 51% yung beyond 60 days di ba? So dun sa beyond 60 days, ano yun? 70 days, 80 days? The fact na yung COVID slide nyo indicates that 21% paid, but it took you 2 years. Ibig sabihin nun, it's really way beyond 60 days. Ito yung 51% beyond 60 days. That can mean 61 days, di ba? That can also mean 600 days. So, so pag tinignan mo lahat ng claims, whether completed yung payment or not, ano yung average number of days?
Madam Chairperson, if I may.
Go ahead, Dr. Santos, Attorney Santos.
Madam Chairperson, may I request that Dr. Art Alcantara, our acting SVP for IMS, be recognized, Madam Chair, to present the data requested by Honorable Stella Luz Quimbo. Madam Chair, please.
Thank you, Attorney Santos. Doc Art.
Morning, Madam Chair. To answer po yung question with regards to the turnaround time of PhilHealth for 2020 and 2021, actually we have two indicators po, the good TAT and the crude TAT. And yung yung aming good TAT is around 49 days, and for the crude TAT, it's around 67 days po.
Okay, I think I'll explain myself again. Itong beyond 60 days, in process yan di ba?
Doc Art?
Actually, yun po yung lumalabas sa dashboard po ng PhilHealth, no? For the crude tat po, it's for all claims po for 2020 and 2021 po. Yun po yung aming data na lumalabas po. We are monitoring po this every month po. So we have this report po to be used by the regions for performance monitoring.
Doc Art? But prior to pandemic, ano ang turnaround time nyo? Is it shorter? Kasi may mga regions, I remember in previous hearings, they were saying they can pay as fast as like 20 days or less than 20 days. Prior to pandemic, ano po ang turnaround time siya, average?
Yes po, no, to answer po the question with regards to yung 2019 na lang po, no, yung turnaround time po. Ang good time po namin is 26 days. And for the crude tat, it's around 32 days po. Mabilis po yung processing namin before ng pandemic.
Madam Chair, siguro maganda na lang tanungin later on yung private hospitals.
Okay.
But for now, siguro my next question for PhilHealth is, we had two hearings, Committee on Good Government, where on this matter, which is yung unpaid hospital claims, and I recall quite vividly that President Yaran promised on 2 occasions na mababayaran yung unpaid claims, and at the time it was about 21.1 billion. Obviously, fast forward to today, hindi nangyari yon. And ang sinasabi naman paulit-ulit is may lack of manpower. So ang question ko is, bakit ba may lack of manpower? Is it because of DBM? Kailangan ba ng DBM approval for additional plantilla positions? And then related questions would be, ano yung request ninyo sa DBM for additional plantilla positions for claims? And number 3, did you consider hiring, for example, JO o yung tinatawag na job order? Alam kong ayaw ni Kongging ng acronym. Yung job order kasi pwede kang mag-hire kahit na hindi plantilla position. Or number 4, tulad ng ginagawa ng ibang government financial institutions, tulad ng Pag-ibig Fund, na nag-outsource. If I'm not mistaken, ang Pag-ibig Fund, ina-outsource ang certain segments talaga. So, did you ever consider outsourcing claims processing? So, yun ang related questions po. Ibig sabihin, ano ang possible solutions dito sa kakulangan ng tao? Kasi, ang dami niyo pong pera pag titignan natin yung reserves, over 100 billion. At itong problema na pinag-uusapin natin ngayon is recurring. Parang po tayong sirang plaka. And paulit-ulit din po yung sinasabi po ninyo na kulang sa tao. So, hindi ba once and for all, tuldukan na natin at hanapan natin ng solusyon? At itong mga nabanggit ko, tulad ng pag-hire ng JO, pag-follow up sa DBM, pag-outsource, hindi ba kaya niyo yan as a GOCC? And are these options, were they ever considered by the board?
Attorney Garan?
Madam Chair, can we please recognize Attorney Santos? Thank you.
Madam Chair, hindi po ba pwedeng si President Yaran ang sumagot? Kasi siya naman po ang CEO. Ang tanong naman po natin are very macro policy decisions na sa tingin ko po dapat alam ng CEO.
Okay, thank you. Thank you, Madam Chair. Paborito talaga ako ni Madam Stella.
Yes po.
Thank you, Madam Stella. We have those plans. No? Number 1, outsourcing. We have those plans of outsourcing. Now, with GO, we have hired GO. And as a matter of fact, aside from the GO, we even went to the we have been doing the process of using our outreach staff, no? What we call this, we call them takers, no? To help, to give support to the processing of claims, no? And this matter of having our outreach people helping in the process is even extended up to the March 31 of this year. So ganun tayo kaano. And with respect to the plantilla po, ang ano natin po dito, meron na tayong iniisip na ano, as a matter of fact, sinimulan na itong reorganization, Madam Chair, in deference also to the proposed bill of Madam Stella, no? So yan po ang ano. Pero po ang paggawa ng processing, ibig sabihin, the matter of doing the processing is not an easy job. And it requires somebody in the PhilHealth that is already conversant of the matter of processing. Kasi andyan this is money matters. This is not just clerical job, accounting job. When there is error, it has to be reversed. If there is overstatement, it has to be what we call reclassified. Ito hindi basta-basta to. Kasi this involves money. And pagka nagkamali ka dito, ay nako, andyan ang kuha, no? Good enough that we have itong policy about recovery of overpayment. Meron tayong policy na gano'n. And at isa pang problema po dyan, kanina na sinabi na po kanina, na since time of memory, ito na pong problema ang ang pagbayad po. Tama, the very good Congressman Stella Quimbo is right. We have money. So, ang HCIs po, ang hospital should not be worried. We have money. Ang problema lang po pagbayad. Ang pagbayad na nasa palisiya at saka may safety nets, no? So, hindi naman po, after that investigation ng dalawang kapulungan po, marami na pong nag-resign. May mga tao natin. And sa Iloilo nga, may dalawang doctors na nag-resign. You see? So, hindi po basta-basta naman ang pag-ano sa kanila. It's not just easy as picking somebody to replace their ano. There is a process, there is a civil service requirement, there is that board. All those things have to be considered. And the most important thing, Madam Chair, is we have been overwhelmed. We have been overwhelmed by the receipts of claims from our partner hospital. You could just imagine, from 31,000 a day in 2020, it now went up to 39,000 in 2021. And that is a jump of 25%, Madam Chair.
Madam Chair.
At hindi naman po, please continue me, Madam Chair, hindi naman po nagdagdag ang ating personnel complement. Nabawasan pa nga po because sabi ko nga, doon sa resignation ng mga tao natin, yung mga matataas ang pwesto, at saka doon mismo din po sa not so much mataas ang pwesto po.
Madam Chair.
Yes,
Ilan po ba sa ngayon ang mga personnel na naka-assign sa claims processing, yung kabuuan?
Madam Chair, thank you. Can we give us some time?
900.
Per coaching here, it's 990 people, Madam Chair, for processing.
And what do you think, based on your studies, is the required number?
Attorney Garan, 990 all over the Philippines and all regions,
That's right, Madam Chair.
with 31,000 claims filed every day.
Per day. Clearly
Yeah.
impossible. So,
Pero-
ang tanong, Madam Chair, is Ilan ang kailangan nila? Dapat alam nila yon.
Your projection, Attorney Garan.
We will let us recognize, Madam Chair, Mr. Dennis Lim for this. But before Dennis Lim would answer, gusto ko lang sasabihin, maliban po sa personnel problem natin, no? Personal depletion problem natin, malinaw po talaga na ang problema talaga natin is IT po talaga natin. Pabalik-balik yan. IT po ang problema natin. Anyway, meron na tayong may approval na tayo sa ISSP, no? And this matter is now being what we call this, we are waiting for the approval ng DICT, no? Para masama na ito sa procurement natin and then back to the board. So we recognize, Madam Chair, Mr. Dennis Lim for the supposed number of tao para dito sa kuha natin.
Mr. Lim?
Claims
Mr.
natin.
Dennis Lim, you have the floor.
Magandang maga po sa lahat.
Sir Lim, can you turn on your video?
Yes, ma'am. Thank you po. Ma'am, I'm currently work from home po kasi COVID suspicion po ako ngayon. So the data is being handled by my team and I already communicated with my team insofar as how many are the existing number of claim processors and how many we will be needing in our proposed reorganization po. So can you give me about 5 or 10 minutes so that I will be able to concretize my response on that, ma'am?
Next time po,
Well,
bago giving, kung pwede lang po sana mag-prepare kayo, no? But alam niyo po yun, mga basic information po yung itinatanong sa inyo na dapat ay alam po ninyo kahit nakapikit po kayo, alam niyo dapat yan, no? Kahit saan kayo tanungin, dapat alam din po ninyo yan. So,
that's true, ma'am. That's
okay,
true. Sorry.
Mr. Lim will give you 5 minutes to get on the data.
Yes,
And
ma'am.
while we're waiting, ma'am, doon po sa COVID slide na naka-indicate from January 2020 to January 6, 2022, so span of 24 months, 21% lang ng COVID inpatient claims ang paid. So merong 79% na hindi pa bayad. Ano yung age ng 79% na yon? Ilan buwan na? Gaano katagal na yung 79% na yon? Kasi lagi nyo sinasabi sa amin, hindi 40 days lang to process claims. Hindi ko maintindihan. If I look at all your slides, they just don't make sense. Diba? Waway. How can that even be waway? Right? 40 days, but then you have 79% of COVID claims within 24 months na hindi pa processed, hindi pa bayad. The numbers don't round up. What's the explanation? I think I've known Huawei for the longest time. He's very technically equipped. Maybe you can shed some light on this question.
Anyone from PhilHealth? Attorney Garan?
That Huawei is can answer it, Madam Chair.
Okay.
I know that Huawei worked in claims for the longest time. So kabisado mo siguro to.
Hindi po ako sa Mr. Chair, Madam Chair, Kong Stella, hindi po ako taga-claims actually. I'm with operations, but yun nga, no, there's a big chunk na still unpaid. Now ang problem
So that question is, how old are those?
Yeah. So
para maintindihan namin bakit nag-umaalma ang private hospitals. Kasi pag sinasabi ninyo 40 days, you're telling me the hospitals are not willing to wait 40 days? I don't think so. They have my guess is their operations are big enough to sustain a 40-day waiting period. And I will ask the hospitals later on. So it cannot be 40 days. It cannot be 40 days, right? The fact that you have 79% of COVID claims within a period of 24 months that continue to be unpaid.
So the if I may, Madam Chair, Kong Stella, the 44 days, 45 days turnaround time is only for good claims. So
Correct.
tama po kayo, yung successful. Now
Yes.
there's a big chunk of claims that we have returned, no?
Correct. No, and hindi lang returned, yung in process. At yun ang
Yeah.
pinakamalaking problema.
Yeah,
Gaano na
yes.
kagurang yung mga in process na yan.
Yeah, so I think
So it's a big concern, Madam Chair, that you don't even know that number, top of mind. How can
Actually-
you even begin to think about hiring additional number of people, etc., when you cannot even diagnose the problem? You cannot even tell us what the average age of all of these in-process claims are.
Kung Stella,
Um,
I think President Almora wanted to interject.
Ay, sige ma'am.
President Almora from PK.
Yes, Madam Chair. We would like to propose a solution how to speed up the processing of claim, because the problem right now is the delay in the processing of claim and the denial of claims. And we have been going back and forth on this matter. But first, before we give our proposal on how to speed up, let me just bring you back to how the payment is made in PhilHealth. When we started PhilHealth, the payment method was pay for service. So we pay for each service as given to the patient, meaning we look at what are the diagnostic procedures done on the patient. Is X-ray done, CBC, urinalysis, fecalysis, and we look at them one by one, and that is what we are going to pay. For the medicines, we look at each medicines, how many tablets, how many medicines are given, and then we total all those things, and so we pay for those services given to the patient. That is very laborious and very taxing on the PhilHealth personnel. So there was problem in the delay of payment because it is laborious, and so we came up with the case rate payment, wherein we pay for the case. Meaning we pay for the case, meaning Juan de la Cruz is admitted on this date and discharged on these days with so many number of days confined with this diagnosis and proper diagnosis and proper treatment, and so we pay. There's no need to scrutinize the laboratory procedures done, the medicines given, because we are paying for the case. As long as we can prove that Juan de la Cruz is really admitted on that date and was given a diagnosis and was given treatment, then we pay. That is the purpose of the case rate, to shorten the payment time. But initially, that is what PhilHealth did, and in fact, we had even had the efficiency gain, because if the actual charges for the patient is less than the case rate, then we are still being paid the case rate, because that is considered efficiency. We are being efficient in the way we manage the case. But just recently, we removed that efficiency gain, which is also a problem for the hospital, because we need that efficiency gain. So why don't we go back to the first time we implemented the case rate, wherein we just process the case and then pay the rate? That's it, case rate. Why are we going back to the pay for service? What we are doing right now, our evaluators, what they are doing right now is they are going through one by one through the medicines given, the procedures given, and all those things, which is basically going back to the pay for service method. So our suggestion is we just make it plain and simple. We do case rate payment. If there is a patient is actually admitted, there is actual diagnosis made, there was properly diagnosed and properly treated, then we pay right away. I don't think that will take more than 5 minutes to evaluate a case, or more than 1 minute to evaluate, if we are going to stick to the case rate payment. So that is our suggestion, Madam Chair.
Madam Chair, did PhilHealth officially abandon the case rate system? Are they back to fee for service? May we ask PhilHealth?
Madam Chair, no, we did not abandon all case rates po.
Oh, yan din ang pagkakaalam ko. So, I guess hindi rin talaga nagkakaintindihan ng mga private hospitals at PhilHealth?
Mr. Chair, baka yung pay whichever is lower, ang ibig sabihin, Madam Stella.
Yeah, kasi ang pagkakaalam ko, case rates pa rin. So anong hindi ko maintindihan where Dr. Almora is actually coming from, because pagkakaalam ko, you continue to pay case rates, and that's correct?
Yeah, Madam Chair, if I may, yung
Yes.
nagkaroon kasi tayo ng pay whichever is lower policy po, wherein before kasi, di ba, case rate, kahit anong gastos, yun ang case, babayaran. Pero ngayon, naglabas tayo August 22 ng policy which says pay whichever is lower. So the
so now they have to compute. Now they have to compute the fee for service.
Hindi naman pay for service, they have to compute everything.
Yes,
So that
but
they're
like-
more or less. Ma'am. Opo.
it doesn't make
Pero
sense.
why, Kong Stella, pero kung
Opo,
titingnan mo, ang case rates kasi, sinimplify natin yung process
Correct.
ninyo. The old ways, no? So, nung whichever is lower kayo, you need to compute everything again. And
Correct.
whichever is lower. So, yung interpretation talaga ng hospital groups dyan, it's like, we're back
Fee for
to
service.
fee for service. So,
Yeah.
yun yung isang, I think na-discuss din natin yan last hearing, no? Briefly. Ano ba ang implication nun doon sa current policy ninyo on case rates? Go ahead, Kong Stella.
My question na lang for the private hospitals, Madam Chair, bibilisan ko na, I'll ask all my questions. When you say disengage, explain natin sa kababayan natin, ang ibig sabihin nun, hindi na kayo kasama sa PhilHealth, which means kung nag-disengage lahat ng private hospitals, ang mga PhilHealth members, kapag gumamit ng private hospital, wala na silang quote-unquote discount, di ba? Babayaran na nila buong buo yung kung anong siningil ng private hospital. So, I have two related questions. One is when you say we want to disengage from PhilHealth, are you contemplating a permanent disengagement? That's my first question. Number two, and if the answer is yes, can you explain to us why that makes business sense? Kasi hindi ko maintindihan, are you trying to say that without PhilHealth, you will actually make more profits? Kaya ko pinipilit alamin yung ganun ba kahaba talaga yung claims processing period such that talagang ikalulugi ninyo na not joining PhilHealth? Kasi para sa akin, malaking bagay na merong nakasama kayo sa PhilHealth because whatever PhilHealth cover you get, let's say 30%, from the perspective of a patient, that's a discount. So that's already an incentive for the patient to use a private hospital. So when you completely disengage, wala na yung ganung financial incentive available to patients. So it doesn't make sense to me. So maybe you'll have to explain it a bit more to me that a permanent disengagement from PhilHealth is actually in a certain situation where PhilHealth doesn't pay on time. It actually means more profits for private hospitals. Kasi parang
Almora.
is that really a credible threat na magpo-permanently disengage kayo?
Dr. De Grano.
Yes, let me clarify, Madam Chair.
Okay.
Our engagement with PhilHealth is basically to make pautang, to extend credit to PhilHealth. Pinapautangan namin ng PhilHealth dahil para mas madali sa pasyente, meaning hindi na out of pocket ng pasyente. So that is our engagement with PhilHealth, pautangan ng PhilHealth. So if we disengage, ang ibig sabihin hindi namin pautangan ng PhilHealth. Meaning magbabayad yung pasyente out of pocket, but we can help them process so that they will collect directly from PhilHealth. Sila na yung magko-collect sa PhilHealth yung benefit nila at hindi na yung hospital ang magko-collect ng benefit of the patient. So that is the meaning of disengagement. It is only the pagpapautang that is being disengaged, Madam Chair.
Thank
Okay.
you,
So now,
Dr.
thank you for the clarification. Madam Chair, yung tinanong ko na lang po sa PhilHealth para I can yield to the next Kong.
Mr. Lim, yeah? Mr. Dennis Lim.
Thank you, ma'am. Based do sa data po namin, correctly mentioned by the COO, no, there are existing 900 processors. Ano po. The number already includes augmentation ng job order personnel. Ano po. Actually, the approved 2007 structure only provides a lower figure. I think it's about 700. Insofar as the proposed organizational proposal is concerned, we have considered about 1,400 claim processors. Ano po. Kaya lang I would like to expound on this, Mama na po. Ang approach po ng management is not to increase the number but to revisit the process by which ginagawa po yung processing. Ano ba? That will be the first. Yung second naman po, yung organizational design wherein accountability will be defined in such a way that we can pinpoint persons na who is accountable for the delay. Ano po. Sa ngayon kasi, ma'am, para pong imbudo ang pasok ng claims eh. Isa ang pinapasukan, tapos dina-allocate po yan based sa number of available claim processors. Ngayon po, dinisign po namin sa proposed structure na para po siyang ina-align po natin in terms of the number of hospital by province or by geographical dimension. So halimbawa sa region po ng CAR, 7 pong probinsya yon. There are 7 teams po responsible for 1 province each. So para po talagang ang pasok doon, halimbawa Ifugao, all claims of Ifugao, doon lang po papasok. Tapos yung team na po yon ranges from 10 to 15 personnel. So in essence, ma'am, doon po namin ina-address para ma-facilitate yung processing. The last, ma'am, is the contemplated outsourcing, ma'am. Ano po? Kaya lang outsourcing will have to be defined in such a way na talaga pong malinaw siya and it will not happen immediately. So 3-prong po ang approach namin. Yung interim po na ngayon and before the reorganization and the reorganization dimension and eventually the outsourcing element. So we believe na based dun sa design na yun, ma'am, we will be able to address the current backlog and improve efficiency. Thank you, ma'am.
So final na talaga, ano yung commitment ng PhilHealth moving forward? What is the commitment, the specific commitment of PhilHealth with regards to unpaid claims and with regards to all of these plans to increase manpower, etc.? Is there a specific time frame na naiisip ninyo?
Ma'am, basically po, no?
Maybe Madam Chair, kay President Yaran na lang para talagang manggagaling na talaga kay sa pinaka-boss natin.
Attorney Garan.
Thank you, Madam Chair, for the question. Now, our concern really right now is to pay, of course. And we have strategized things on how to do it. First, we do the face-to-face reconciliation with those HCIs to be done by our pros, meaning the provincial regional offices. And after the reconciliation of accounts, because never will the books maintained by the healthcare institutions and the PhilHealth will have the same amount. Will amount to the same figure. There will always be discrepancy, wittingly or unwittingly, and that matter has to be reconciled. And that's why we do what we call book reconciliation. And after that, the processing will do, whether it is for COVID, for non-COVID, and then we have to observe our top, no? Para hindi tayo mapulaan ng ng ating partners, no? And for those problema talaga dito is yung mga returns, no? Yung sa returns po kasi the reason why nagtatagal yung returns kasi yung pagbalik ng mga claims, it's a systems generated. Pero ngayon meron tayong improvement na ginawa, like aside from systems generated na sinasabi na this claim is being returned, ngayon pinasulat na natin sa ating processor or sa ating doon sa kung saan man sa pro natin kung ano ang specific na kailangan dito sa claims na idagdag para pagbalik nito ay pira na po. So specific na po ngayon. It's not only machine generated. So with that,
Attorney Garan,
maganda na.
if I may cut you lang po. Kanina, very specific na mention one of your staff, Attorney Santos yata, on the pressing problem on IT structure. Ano po ang target nyo on that project? Target po within the year po ba maaayos ang IT infrastructure nyo?
Madam, can we recognize Dr. Art?
Doc Art?
Thank you, Madam Chair. No? Actually, may mga na-initiate na po kaming mga initiatives po na nabanggit po doon sa mga previous hearings po. Number 1 po yung aming integrated systems po. Nakapag-procure na po kami ng phase 1 ng integrated system. Nakabili na po kami ng enterprise resource planning where naka-integrate na po ang aming finances sa procurement, sa asset management, sa inventory, sa HR po. Number 1 po yun. Number 2 po, as nakipag-coordinate na rin po kami sa Globe. Kasi po, existing po namin is yung PLDT for the production po, yung pagsasubmit po ng mga e-claims. Ang ginagawa po namin, nakipag-usap na kami sa Globe para madoble po yung bandwidth namin para po mas maluwag po yung traffic at mas mabilis po napapadala po yung mga e-claims sa PhilHealth po. Unfortunately po, ang sabi po ng Globe is they have to upgrade po yung facility nila. Kasi po hindi po kaya po ng kanilang facility doon sa bandwidth po ng PhilHealth. And for the others po, like for example, yung PPP, some of our IT operations po will be outsourced na po. Para
Doc Art, if I may cut you, Doc Art, if I may cut you. Ang question ko, target nyo po, hanggang kailan po yung project na yan matatapos?
Within the year po.
Target nyo po.
Within the year po.
Okay, go ahead. Attorney Garan, if you can wrap up on the question ni Kong Stella, your commitment, way to go for or moving forward sa PhilHealth po. We have 3 more members who wanted to ask question.
Okay, thank you, Madam. At the moment,
Madam Chair, specific na lang na commitment kung magkano ang babayaran when. Di pa pwedeng ganun na lang. Ano ang target ninyong bayaran na amount at saka kailan?
Attorney?
Itong in process po namin na 25.45 billion po. We have to pay this in 6 months' time.
Thank you. Okay na, Kong Stella.
Yes, salamat po. I'll yield to the next po.
Okay.
Maraming salamat po.
Would like to recognize Kong Ging Swansing. Thank you for patiently waiting.
Thank you, Madam Chair. Sobrang payat mo. Good morning to everyone. My first question is to Dr. Almora. Dr. Almora, are you aware of the reasons why there are delays in the payment of your claims? Nabanggit po kanina, it's nag-take note po ako, sabi personnel, policies, and IT system. So, are you aware of the reasons for the delay?
Thank you, Madam Chair. I can only surmise, Madam Congressman, that there are other reasons other than those mentioned, because policies are made in the central office, but payments are made in the regional offices. So it is the payer is the regional offices, not the national offices. So that if there are confusing orders or circulars or vague or unreasonable circulars being handed down to the regional offices, that they are reluctant to act on them, especially in light of what is happening to their co-employees in PhilHealth that are being sued for one reason or another. And that is what we perceive is the major reason, their fear of acting, because the real problem is actually in the COVID claims only. There is delay in the non-COVID claims, but we understand that this is the three mentioned reasons is the reason for the delay of the non-COVID claims. But for the delay of the COVID claims, there is more reason than those three mentioned. So there is really a need to for PhilHealth to dialogue with the regional offices, the national management of PhilHealth, to dialogue with the regional offices to really for them to find out really the reason, because apparently there is reluctance on the regional offices to pay. And further, Madam Chair, I would like to clarify my suggestion a while ago about the fee for service and the case rate. Our suggestion is to implement the real case rate payment, because the real case rate payment is for a fixed payment, meaning, okay, let me state it this way: the fee for service is a payment which is not fixed. For example, pneumonia, you pay for the services given, the medicines, the diagnosis. There is no fixed amount. But in case rate, there is a fixed amount for pneumonia. And whatever diagnostic procedure or whatever medicines is given, you are going to pay that fixed amount. So there is no need to scrutinize what is done to the patient, and that will speed up the process. The reason why we move from fee for service, which is not fixed, which is dependent on how much was really given, to a fixed amount for every diagnosis and treatment, is so that we will solve the problem of delay, which was a problem before. Now, what we are doing, what the evaluators of PhilHealth is doing now, is to scrutinize one by one all the medicines and everything, and looking for reason to deny rather than reason to pay. Because actually, if they just have to stick to the real purpose of the case rate payment method, as long as you can identify that there is an actual patient, actual admission, there was diagnosis made, it was attended, diagnosed, and treated, then you don't have to go through all the details. You have to pay immediately, because anyway, the amount is fixed. Whether it is more than or less than the amount, you have to pay because it is a fixed amount. And I don't see why we have to have much delay, because the purpose of case rate is to do away with the laborious process in the pay for service. If we only have to implement it the way it was intended to be, then I don't see any delay, Madam Chair.
Madam Chair, can we get a reaction from Attorney Garan on the suggestion for the solution?
Attorney Garan, your reaction to the suggestion of Dr. Almora.
Thank you, Madam Chair, for that. Well, this problem stems from the findings of the COA about the amount that is supposed to be paid by PhilHealth, as stated in the supposed SOAR, statement of account, and the scheduled ECR or all case rates that we are having right now. So the COA observed, it's the observation of the COA that why has PhilHealth to pay the ECR if which is bigger in that event, if the statement of account only speaks so much lesser than what is scheduled, what amount is scheduled in the ECR. So yun po, parang iniisip ng COA na bakit magbayad ng malaki na maliit man lang talaga ang gastos dito, maliit man lang ang cost per statement of account. Kaya sinasabi ni Dr. Almora na ano po, the payment should have been based on yung tinatawag na efficiency. Efficiency meaning mas madaling nagamot sa isip ko, I am not a doctor, no? Mas madaling nagamot ang sakit. And it required only so much a little to what we call this to paggamot ng isang sakit. So ang tawag nila diyan ay efficiency. So but the COA has other thing in mind na PhilHealth should have only pay the lower of the two, meaning kung mas mababa ang kung mababa ang statement of account po actual, ang babayaran po ay ang actual. Now, kung malaki naman actual kaysa case rate, ang case rate po ang babayaran po. Thank you po.
Dr. Almora, kasi para maayos na natin to,
Yes.
no? Kasi pabalik-balik na tayo, Madam Chair. So, ano po reaction ninyo sa sinasabi
Yes.
ni Attorney Gran? Ito po bang action ninyo is because of the audit findings? Kaya ninyo ginawa ito? So that our private hospitals will be able to understand kung saan kayo nanggagaling, kasi ang sinasite ninyo, the cause of delay is because of the IT, the personnel, and the policies, no? Ang sinasabi ni Dr. Almora is yun yung sa non-COVID. Pero dito sa COVID, is it because the reason why you're doing this is because of audit findings?
Ang pagkaalam ko po ang sa yung tinatawag na the lower of the two does not distinguish whether it is COVID or not, whether COVID or non-COVID. It's overall po. And of course, we have to heed the observation and recommendation of the COA, because otherwise we will be.
Kaya nga po, ang tanong ko po sa inyo, is it because of the COA findings or recommendations? Kaya po ninyo binago?
Certainly po.
Okay.
Certainly po, because it will COA po.
Okay. Thank you, Attorney Garan. Dr. Almora, any reaction?
Yes, Madam Chair. My suggestion has nothing to do with the efficiency gain. Just for me to explain the efficiency gain. The efficiency gain is that the amount in excess of the actual charge, meaning PhilHealth is going to pay 15,000 for pneumonia, but the actual amount incurred in the management of the patient is only 10,000. And that is in the statement of account of the patient. So there is a difference of 5,000. When case rate was initially implemented, the case rate method was initially implemented, that amount or that excess amount of 5,000 is given as efficiency gain, meaning the hospital has managed the patient efficiently and they are entitled to that gain, meaning they are still, even if the actual amount is 10,000, they are still paid that fixed amount of 15,000. But during a hearing in Congress, that was deemed to be improper. So it was declared that this is not allowed, and therefore PhilHealth came out with a circular modifying the case rate payment, removing the efficiency gain. We did not raise any objection to that, Madam Chair, because we know that it is not from PhilHealth. It is the decision of Congress or Senate. I am not sure now, Madam Chair. So that is the decision of the legislative. So we did not question it. But my suggestion has nothing to do with that, Madam Chair. Case rate payment method is a fixed amount for a case, meaning, let's say, pneumonia case, pay 15,000. Acute gastroenteritis, the fixed rate is, let's say, 5,000, pay 5,000. There is no need to scrutinize that, which is the cause of the delay. And that is the real intent of the case rate payment method, as differentiated from the pay per service method, meaning the pay for service, which was the original payment method. The original payment method was the pay for service, meaning there is no fixed amount. When a patient was diagnosed and treated, the actual amount incurred is the amount that is paid by PhilHealth, regardless of what the amount is.
Dr. Almora, Tongging, tanungin lang natin, do we have na representative from COA? Kasi we've invited them. Ma'am Sylvia, do we have na COA?
Ma'am, ma'am, wala pa po, ma'am.
Okay, we'll just write a letter sa COA.
Yes,
Kasi
ma'am.
in relation, for the information then of the body, ang all case rates ay nasa Universal Healthcare Law po. No? So allowed yon. At baka hindi rin aware yung COA na mismong nasa batas po ng UHC law, yung all case rates or ACR and the global or prepaid payment, no? Yun yung nakasaad natin, whichever is effective or magiging efficient strategy for PhilHealth, no? For the benefit of the Filipinos. Go ahead, Kongging, if you still have questions.
Madam Chair, maybe what we can do now is, since wala yung COA, can we get a copy of the basis of PhilHealth for changing their policy? Pwede po ba yon, Attorney Garan?
Madam Chair, we will gladly submit to your honor, the committee, a document that would show particularly an audit findings, no? The audit findings that would and directives that would answer to the question of the honorable Sansing. Thank you po.
Madam Chair, siguro pwede naman i-email kaagad kay kay COMSEC yung COA findings and recommendations na naging basis nila. I'll move to my next question, Madam Chair. Yung problema natin is in process na mga claims, return to hospitals tapos denied, no? Yun po bang return to hospitals, may pag-asa pa yon na mabayaran compared to denied? Ang denied kasi denied na talaga, hindi siya mabayaran. I am right to understand that way?
Madam Chair, ang yung return to hospital ay medyo hindi po mahirap yon. Kasi meron ng tinatawag na formal requirements ang kailangan para po magiging payable na ang yung claim. Say for example, statement of account hindi na
ang tanong ko lang po, Attorney Garan, is yun po bang return to hospital ay may pag-asa pa na mabayaran compared to denied na hindi na talaga siya mababayaran? Tama po ba ako?
Ay, hindi lang po pag-asa, talagang babayaran po yan, Madam Chair. Sigurado mabayaran ng pag nasubmit na po yung nire-require ng PhilHealth po. With respect naman to po doon sa denied claim, hindi naman ibig sabihin na talaga walang pag-asa. Meron pa rin kasi meron naman iakyat natin yan sa isang appeal, isang sa isang division dito sa PhilHealth kung saan ay talakayin kung ano talaga ang nangyari doon. So may chance pa po na mababayaran po.
Okay. Kasi hindi ko po maintindihan, Dr. Almora. Siyempre, alam niyo yung requirements to comply para mabayaran ng PhilHealth. Pero bakit meron pang nadi-deny? Kasi meron lang ma-deny kung may violation or may kulang. So, bakit hindi siya lahat na re-return to hospital? At merong denied. Ano po yun? Kasi yung denied parang kahit maliit lang yung porsyento pero malaki yung amount, ang haba ng proseso. mahaba na nga ang pagbayad, tapos may denied pa, so mas lalong humahaba yung pagbayad. So ano po yung problema dun sa denied?
Yes, there are several reasons for the denial of claims. About 10 of the top 10 causes of denial of claims, I consider them a 9 out of 10 of the top 10 causes of I consider them arbitrary in nature, because claims are being denied not because of the fault of the hospital, but it's either because of the fault of the third party
Provider.
provider,
System provider.
the IT. It's a fault of the physician in charge of the patient, or it is the fault of the PhilHealth processes itself. So, for example, I cannot remember all the 10 causes, but for example is the double filing of claims, which is the cause for denial and actually a cause for administrative case. The double filing of claim is just technical in nature. It's just what would I say, clerical or technical. It's either because of the IT provider, wherein there is no prompter that the document sent was already sent. So there is no feedback that the document has already been accepted. And so the one submitting the document makes a second attempt to submit because he is not sure that the document has already been passed on to PhilHealth. And that would appear as double filing of claim. Or in some cases, there is in the billing section of the hospital, there are several clerks processing claim. One clerk has already processed that claim, and another clerk, by mistake, processed also the same claim. So that is just that is just procedural or technical in nature, but never malicious in intent. Another cause for denial is the not within acceptable management, not within acceptable mode of management. But the hospital has nothing to do with it. Hospital does not diagnose and does not give treatment. Does not treat and diagnose cases. It only provides the facilities that will facilitate the diagnosis and provides the medicine for the doctor to give to the patient. So the hospital has nothing to do in what medicine to give to the patient. It is the doctor. So if it is not within acceptable mode of management, it is not the fault of the hospital. It is the fault of the doctor. But what is being denied is the claim of the doctor, the hospital, including the doctor. So there is a need to differentiate, and that is one thing we are asking PhilHealth to punish also only those that are in violation, meaning the professional provider is separate from the institutional provider. Ethics would suggest that the hospital cannot dictate the doctor on what to do. The universal right for doctor provides that they are autonomous. They should not. Nobody should dictate to them what they will do to the patient. Their management of the patients is only according to their best knowledge and the best interest of the patient. So
Okay, Dr. Almora, are you penalized because of the denied claims? Meaning, pag merong problema, like for example, duplication of claims, no? Are you penalized because of that?
We have been pointing out that there is a big problem with the IT provider. The IT provider is accredited by PhilHealth. So
are you penalized by PhilHealth because of those violations na nagdouble ang claims, mga ganon? Hindi naman.
For double filing of claim, it is considered an administrative case. It is a violation. Malice is imputed, and
naapektuhan po yung mga hospitals.
We can be subject to denial of accreditation.
So that's
in addition to the denial of payment of claim.
Okay. So meaning, Madam Chair, Attorney Guran, dapat tama naman yun. Hindi dapat ma-penalize yung hospitals for the offense of the third party provider.
Attorney Garan.
Madam Chair, to answer the question of Madam Sonsing, I commiserate with Dr. Almora. Like sa double filing, no? Because of IT problem again or connection problem again. Ito hindi na penal ito, baka sa hospital. Yung pagpadala ng ano, tapos tingin mo ayaw, just like sa cellphone. Tapos ulit. So maya, pag nag-ulit na, yung pala, pag nagka-signal na, doble-doble na. Kaya nagkaroon ng double filing. Which under our policy is really a taboo. It should not be done. Kaya nga, meron tayong protest and appeals, what we call this, protest and appeals review division department here para po silipin, para po imbestigahan, para po para bigyan ng husga yung sinasabi na double filing. So ito po, by experience po, 1 year na po ako dito, meron naman po maraming na-dismiss po na kaso about double filing. Kasi pag lumabas naman na hindi naman kasalanan talaga ng doktor, kundi kasalanan ng clerk. Kasi, Diyos ko, ang hirap mag-aral ng isang doktor. Kayo po ay doktor po. At saka, sa halaga ng 1,000, tapos mag-double filing po kayo. Kaya, ang mga investigador po, mga abogado po, nakaintindi po yan. So, dismiss po ang kaso. And then,
At Attorney Giran, kasi may naghihintay pa po, mayroon pang dalawang magtatanong. Ano? Okay, ganito. Dr. Almora, magbabayad daw sila, no? Kasi 25.45 ang for payment nila, tapos nagbayad na sila ng 12.06. So may balance na lang sila na 13.39. Ma-appease na po ba kayo doon na magbabayad sila in 6 months?
Madam Chair, wala naman kaming pagdududa. The PCO has ever since, wala akong duda sa sincerity niya na magbabayad. Ang problema lang talaga, Madam Chair, is in the regional offices. Kaya ko po sinasabi na wala namang problema sa intensyon ng mga top management natin. Ang problema yung sa regional offices dahil sila ang nagbabayad. Sila yung maikukulong pag dinimanda sila ng NBI o ng PhilHealth. Sila yung matatanggalan ng salary na magre-reimburse. Kaya takot na takot silang gumalaw when there is ambiguity, when they are confused about the circulars they are receiving. So there is a need to really clarify these matters sa regional level para matanggal yung fear nila. I don't know what has to be done, but we have to remove the fear because I believe that it is really the fear factor that is paramount in the regional offices. Takot po sila na madimanda. Yun po yung kailangan ma-resolve dito para ma-process. Kasi kahit ano pong sabihin natin na gusto natin magbayad, kung yung mga taga-regional offices ang hindi nagsasabi, meaning their commitment has to be the one that we need, Madam Chair, because they are the ones that paying. Saka lang namin maasahan na mababayaran kami.
Almora, Kongging, that's
Yes.
why kanina when at the early part ng ating discussion, nire-reiterate ko sa PhilHealth yung policies based dun sa previous natin na mga hearings kasi ito yung major cost ng unpaid claims, no? Confusion in the implementation of the circulars, no? Like yung simple question on the definition of probable cases wherein they implemented as early as March or April 2020 and coverage niyan up to June 2021. And yung mga precedent na nangyari na mga cases among PhilHealth officials or employees because they paid claims based on their interpretation na tama naman na bayadan nila on the basis of the existing circulars that they released, no? So that's why we're asking PhilHealth that once siguro kailangan talaga linawin na nila yung policy. Although sinabi ni CEO na PCEO na meron na ang COO na memo to RVPs kasi naghihingi sila ng clarification ang mga RVPs natin from the central office, no? Ano talaga ang gagawin nila? Kasi nga may iba-ibang interpretation. At yung na-mention ni Dr. Almora na fear of those people in the ground na baka sila makakasuhan katulad ng mga other employees na nakasuhan or officials. So I think yun yung major factor. It's more on policy direction ng PhilHealth or clarification. Kaya kanina tinatanong ko sila kung yung recent advisory is enough for the RVPs to interpret na okay, pwede na tayo magbayad doon sa mga probable. Kasi ito yung bulk ng unpaid claims ng PhilHealth right now, no? Kaya maraming COVID claims ang hindi nababayaran. Well, I think walang problema doon sa non-COVID related claims, no? Nakakabayad naman sila. But doon sa bulk ng ating mga filed claims natin ng COVID, marami hindi nababayaran. So I think yung commitment ng PhilHealth, especially sa top management, na i-clarify itong mga policy na to. Straightforward, ma-orderan yung ating mga RVPs na there's nothing to fear about, no, doon sa implementation based on existing circular.
Madam Chair, thank you very much. Two things ang natutunan ko dito, no? And ito yung two things din na makaka-address ng problema natin. Last na po ito, I would like to get a commitment to Attorney Geran. Kailan po ninyo ma-address yung problema sa regional branches? Na ayusin yung policies para hindi po matakot yung inyong mga tao sa region na magbayad na. So, number 2, Madam Chair, is meron kayang pag-asa na ma-consider ni Attorney Geran yung suggestion ni Dr. Almora dun sa actual universal healthcare, no? Nakapasok dun sa universal healthcare na actual case, ano nga yun?
Case rate.
Case rate.
Actual case rate benefit package.
Yes. Two things, Madam Chair, that I need to get from Attorney Geran.
Attorney Geran.
Yes, Madam Chair, with respect to policy na sinasabi na conflicting policy or conflicting what we call this interpretation by our people, our officials sa provincial regional offices, mismo po yan. As a matter of fact, nag-usap kami kahapon. Kung anong gusto nila. And we committed to them to do what they want about a memorandum that has to be initiated by top management. So, pinag-usapan na po namin yan. And with respect to the suggestion of Dr. Jamie Almora about yung case rate, no? Isa lang po akong tao sa board. So my vote is only one. Iyon po ay dahil inano na po yan, ginawa na po exception ng PhilHealth, rather ng COA. At saka po, kinwestiyon po yan ng Kongreso na bakit magbayad ng sobra kaysa doon sa pagpagamot ng isang tao, isang pasyente. So I think the COA also take precedence on that result of the investigation of the Congress. No? So yun lang po. Ang ano lang namin po, ang ano ko lang po is pag-usapan ito ulit sa board, itong concern po ni Dr. Jimmy Almora po.
Attorney Geran, I would like to suggest you read po the Universal Healthcare Law para po mabalanse ninyo. Hindi po, at saka pwede po siguro i-discuss din ninyo sa COA yung Universal Healthcare Law, no? Para po hindi po tayo mag-violate ng batas at maintindihan po natin yung sitwasyon ng ating mga private hospitals. So yun lang, Madam Chair, merong commitment si Attorney Geran na ayusin nila yung policies para po susunod na ng maayos ang ating mga regional offices. And then pangalawa po, I really strongly suggest po na basahin po ninyo yung nakasaad dun sa Universal Healthcare patungkol po dito sa actual case rate. Maraming salamat, Madam Chair.
Thank you. We'll now call on the last interpellator, I think. Kong Franz Castro.
Thank you, Madam Chair.
Ed.
Can you hear me, Madam Chair?
Yes, loud and clear.
Yes, magandang tanghali na po no sa ating lahat. So, salamat Madam Chair doon sa patawag na meeting na ito para ma-trash out talaga yung problema kasi napakahalaga na ng usapin na ito kaugnay ng kalusugan ng ating mga mamamayan. At syempre yung usapin nung tungkol doon sa yung health services ng ating mga mamamayan. So kanina Madam Chair na pag-usapan na yung policy, aayusin na po ng PhilHealth. Kailangan magkaroon lang po tayo ng time frame no Madam Chair kung kailan yan yung IT within the year. Yung personnel Madam Chair wala akong narinig kanina na nag-ano po ba kayo Madam Chair PhilHealth nag-ask po ba kayo ng additional na plantilla position kaugnay dito for 2022 budget? O meron kayong naka-allot na budget for additional personnel? Kasi kulang po, tingin namin kulang po talaga kayo ng personnel. Meron po ba silang request? Oh?
Opo, Madam Chair, meron na po tayong hiningi dyan doon sa ating reorganization. And even with before the reorganization pa nga, meron na tayong na-hire po doon sa mga pampalit doon sa mga nag-resign po dati sa atin.
Okay, hindi lang po doon sa nag-resign yung kakulangan po na binabanggit natin binabanggit niyo po na mga personnel na inano niyo na request po before this pandemic or before this year. So, andyan na po ba? So, pwede bang matanong Madam Chair, ano yung request po ng PhilHealth sa DBM kaugnay nitong mga additional positions po para sa PhilHealth?
Thank you, Madam Chair. May we ask Mr. Dennis Lim to answer the question?
Marami pong salamat. Maganda pong tanghali, Representative Castro. Ang tama pong sagot doon ay hindi po kami nagre-request sa DBM dahil being a GOCC, ang nag-a-administer po ng aming organizational structure and staffing is GCG po. Nakaakibat po sa batas na ang GCG po ang ahensya ng gobyerno that will review our staffing and approve the appropriate number and kind of positions required by the corporation. Ano po?
Ano pong update?
Opo, yung binabanggit pong numero kanina ay nakapaloob po yun doon sa proposed reorganization ng PhilHealth na natapos na po ng management, nire-review po ng board at i-review po ng board at eventually po ay isasubmit na po sa GCG before the end of this quarter. Hopefully, ma'am, during the remaining period of the year, the GCG will fast track yung kanilang evaluation and come up with their approved organization and staffing for PhilHealth para ma-implement po namin ng 2023. In terms of numbers, ma'am, ang numero po natin based sa existing is about 6,000. Combination na po yon ng job order, casual at plantilla personnel. At ang proposal po natin na already passed upon by the committee created for the purpose is about 8,300. Kung i-concentrate po natin yung numero insofar as yung issue po natin sa claim, ang numero po natin ginagalawan ay yung existing is 763, hindi po siya 900. Ang proposed po na magiging involved sa claim processing ay 1,400. Yung po ay mangyayari lang kung ma-approve po ito ng GCG.
Okay.
Salamat po.
Okay. Thank you, Madam Chair. Kasi kanina, napakahalaga talaga sa tanungan kanina, napakahalaga talaga yung dagdag na personnel kaugnay noong sa pagpaprocess ng mga claim. Kaya magandang nalinaw natin yung kanilang proposal at ano yung mga kailangan o ilan yung mga kailangan. Okay. Pangalawang tanong, Madam Chair, regarding dito, sa ARTA, within the standard po ba, Madam Chair, and representative from the ARTA, yung sinasabi po na within 60-day claim and beyond 60 days? So within the standard po ba yan nung tamang pagpoproseso nung lahat ng mga claims or whatever?
Representative from ARTA. Ma'am Sylvia, we
Good
have...
morning.
Hi, sir. Good morning.
Good morning, Madam Chair, Helen Tan, ma'am, to our representative, Congresswoman Castro. Yes, Madam Chair, the processing time of provided by the ease of doing business na batas po, is 3 days, 7 days, 20 days, or 20 days for highly technical transaction, which means yung mga transaction that involves public health, public safety. So ito po ay normally supposed to be bumabagsak po ito sa 20 days. Subalit, there is a provision that if there is a special law that provides for a specific period for a particular transaction in government, then that special law will take its precedence po doon sa atin pong more general law. So in this case, ang PhilHealth po ay merong 60 days sa kanilang batas. Subalit, Madam Chair and Honorable Congressman Castro, the PhilHealth, the position of ARTA here is that any claims that goes beyond 60 days should actually be acted upon. Ang amin pong recommendation for the DCPM, and I do greatly support the efforts of the PhilHealth na bayaran na po ng 80% agad kapag nag-file po ang mga hospital. Ay subalit, pero pag umabot naman po ng 60 days, ay dapat ho sigurong bayaran ho ito ng kabuuan. So the reason why we did advocate, Madam Chair, also for and supported for the passage or the more comprehensive coverage of the DCPM ay dahil limitado po talaga ang PhilHealth po dati sa mga COVID-related concerns lamang. Subalit ngayon ho sa kanilang ipinasa na resolution ay ito po ay covered na po ang lahat. So we do agree, Madam Chair and Congresswoman Ma'am Castro, that the 60 days should actually be observed by all regional offices.
Yes, ayan. Kaya ko yan natanong, Madam Chair, kasi isa yan sa policy na nagiging cause ng delay. Kaya kung masusundan lang natin yung halimbawa yung standards from the ARTA, dun sa pagpo-process ng lahat ng mga papeles, dapat nasusunod po ito para yung ma-address po natin yung mga delay. And at the same time, kung mayroon na tayong personnel at maayos na po yung IT. So, yun po, Madam Chair. Yung last ko na po na question, Madam Chair, yung tungkol po doon sa, di ba po may mga spike na ngayon ng COVID, latest po kahapon, 33,000. As regards po doon sa, marami po kasi na, Madam Chair, maklarify natin sa PhilHealth, yung kanilang policy on the home-based na treatment doon sa COVID, and at the same time, yung rate na nila doon sa COVID testing. Mahalaga kasi ngayon yung mass testing sa ating mga mamamayan, lalong-lalo na yung mga may affected. So, una ang tanong, magkano na po ba yung rate ng PhilHealth po doon sa mass testing, doon sa testing po? Yung RT-PCR or antigen? Kasi parang paiba-iba po yata ng presyo, or saan po kaya nakasunod yung presyo ng PhilHealth?
I think they have the recent circular Kong. Attorney Garan, you issued a recent circular on the testing. If you can briefly
2,800 ba yon, Madam Chair? Kasi parang nagrereklamo yung ating mga mamamayan, mahal yata ito. 'Di ba mayroon pong nakalagay doon sa guidelines nila na depende ito doon sa magiging situation. Dahil alam naman natin ngayon, ano na ngang testing, ang dami na nating mga testing kits eh. So ganun po pa rin ba yung presyo from the PhilHealth?
Attorney Garan,
Madam
can you
Chair.
provide us, you have a recent circular on that, on PCR testing. I think that's 2021-0021 issued last November 20. Ito ba yung pinaka-recent?
Hello, ma'am. Hello, Madam Chair. Can we please recognize Dr. Lim?
Doktora? Sir, sino pong respond to the question?
Dr. Clean Bautista po.
Dr. Bautista?
Good morning po ulit. Doon po sa bago naming testing package, sinunod po namin dito sa DOH rates. Wherein for the plate-based RT-PCR, if all services and supplies were provided, the package amount is 2,800. And if the test kits were donated to the laboratory, we pay 1,200. This covers screening, specimen collection, and handling, and conduct of the RT-PCR testing and analysis. If there's a third rate po for RT-PCR, if the test kits are donated to the testing laboratory, the cost of running the laboratory and the RT-PCR machine for testing are subsidized by the government. We only pay 800 to cover for the screening and the specimen collection and handling. We also have a new rate for the cartridge-based PCR test. Also, these are in three tiers. One for if all services and supplies for testing are procured and provided by the testing laboratory, we pay 2,450. While if PCR cartridge are donated to the testing laboratory, we pay 700. And if the PCR cartridges are donated to the laboratory, and the cost of running the cartridge-based PCR test is subsidized by the government, we pay 500 pesos. Yun po yung rates.
Okay. Thank you, Madam Chair. Thank you po kay Ma'am Dominga. No? Kasi hindi na po concern ng mga pasyente natin yan, whether donated yan or ano. Kasi ang common na nagiging experience po ng mga workers, mga kababayan natin, fixed na 2,800 ang sinisingil doon sa mga pasyente. So, ito po ba ay sasagutin ito buo ng PhilHealth kung sakaling i-claim ito sa ospital or ng pasyente?
Una po, meron po kaming nilabas na kung sino yung eligible na patients na nakapasa rin po sa subgroups ng Department of Health. Nakalagay po yan sa circular rin namin. So kung nandun po sila, part sila ng subgroups na to be prioritized for testing, then they could claim po. And second po, they should go to the accredited testing laboratories po. Yun po.
Okay. So yun, medyo, Madam Chair, medyo magulo pa rin po, lalo na ngayon, yung spike ng COVID na kailangan talaga ng ilang mga workers o mamamayan natin na ng COVID testing. So, yun lang po, siguro pwede po ba ako mabigyan ng copy or available na ito doon sa ating website? Pwede po ba ako mabigyan ng copy noong sinasabi niyong latest na
We will provide you po.
Okay, thank you, Madam Chair. So yun na lang po. Marami naman ang naitanong sa tanong ko dati. Kanina.
Madam Chair.
Salamat.
Madam Chair.
Yes, Kong Kaloy.
Yeah, may I be recognized, Madam Chair.
Yes,
Pahabol lang, idugtong ko lang doon sa tanong sana, Madam Chair, ni Representative Castro. If I may be allowed, Madam Chair.
Yes, go ahead po.
Thank you, Madam Chair. So, dito sa latest kasi na rates na binigay ng PhilHealth, no? Yung doon sa ranging to 2,450 to 2,800. Ito yung rates kung doon ka magpapatest sa mga public laboratories or hospitals. But in reality, Madam Chair, sa Pilipinas ngayon, majority of the laboratories that conduct RT-PCR testings ay nasa private, no? I think 47% lang yung public, no? 53% yung private. Kaya ang realidad, ang rate sa private ranges from 2,940 to 3,360. Meron pa ngang ibang umaabot sa 5,000 kung gusto mong sa bahay magpa-test, no? So, in this kind of arrangement, Madam Chair, no, in this kind of situation, parang lumalabas, talagang dahil marami ang pumupunta sa private, ang sasagutin lang ba ng PhilHealth dito is up to maximum of 2,800 at magko-copay na ang member dahil doon siya sa private nagpa-test? Ganun po ba ang magiging policy ng PhilHealth? Kasi yung 2,450 to 2,800 na range, Madam Chair, parang kinopya lang ng PhilHealth din doon sa kung ano ang sinabi ng DOH, no? But on the ground, sa realidad, hindi 'yon ang nangyayari, no? Kaya meron pa rin pag-aalanganin, no? Nananawagan nga tayo ng free mass testing doon sa mga vulnerable nating mga kababayan. Hindi naman lahat ng Pilipino gusto nating i-test. But in the past kasi gusto nating magbukas na ng ekonomiya, yung ating mga manggagawa, mga kawani, kailangan nilang mag-test pero nag-aalangan sila. So may we get a reaction, Madam Chair, on this kind of policy na mukhang mahihirapan pa rin ang ating mga miyembro, Madam Chair?
Dr. Clement?
Just like to point out po, we have several providers na rin po na accredited.
Dr. Clement, can you turn on your video so we can see you?
Go ahead. Okay po. As mentioned po, yung rates na bago namin ngayon ay nakabase po yan dun sa rates din po ng Department of Health na supposedly is the maximum cap. So therefore, we are expecting that the providers or the testing facilities will follow this cap. So that, kaya ito naman po, kung nag-provide sila ng services, we are providing also the benefit package that commensurates to the maximum amount that they should be charging the patients. Yun po.
Thank you for the reply, Madam Chair, but hindi pa rin ito ina-address yung usapin, no, na halimbawa ang isang miyembro dahil nga sa kakulangan ng mga available halimbawa in the regions, no, in the provinces, salat naman sa mga pampublikong mga facilities that can conduct a RT-PCR test, no, so pumupunta sila sa private, no. Kung nagkataon, ibig bang sabihin, if this is accredited by PhilHealth, talagang ang i-charge lang ng private testing laboratory na ito ay yung maximum na 2,450 or 2,800. Now, what about if na-charge sila ng more than this kind of amount? So, saan huhugutin yon? Sa bulsa ng ating mga miyembro? Ganun po ba ang mangyayari, Madam Chair?
Dr. Clement?
Yes, Madam Chair. Opo, as I've mentioned, the rates that was mentioned were applied to either the private or government facilities. Tapos po, if in case na, because we are in a state of emergency, these costs are supposed to be, or charges are supposed to be regulated by the government. Such that kung magkaroon po ng gano'n na magsisingil po sila ng mataas, then they can inform po the proper authorities like the Department of Health about the rates that were asked from them to be paid, which is higher than the supposed maximum amount.
Thank you, Madam Chair. But can the PhilHealth also on its own, motu proprio, dahil mga accredited nyo ito, if they are accredited, tapos nag-charge sila ng more than what is supposedly to be charged, can you on your own, Madam Chair, can the PhilHealth also initiate actions on this? No? Dahil alam nyo, kumakapit sa patalim ang ating mga mamamayan, no? Pag sinabi sa kanila, pagpunta nila doon na ganito yung rate, ay kung gusto nilang magpa-test talaga, kahit more than the allowable rate ng PhilHealth, ay magbabayad yon. So, can we get an assurance to PhilHealth to also monitor yung mga accredited nila? Kasi nagtatako ako, Madam Chair, if I can recall it right, previously, yung package kasi ng PhilHealth sa RT-PCR nila ranges from 2,287 to 3,409. No? Tapos nung maglabas lang ang DOH ng kanilang cap, no, hanggang 2,450 to 2,800, binaba rin nila. But again, as I've said, hindi yun reflective of the rates happening on the ground. At in the end, ang nagpapasan din itong additional cost na ito ay ang mga miyembro ng PhilHealth, Madam Chair. So again, can we get a commitment from PhilHealth to look into this, no? Especially now, no, na nagkakaroon nga ng exponential spike because of this Omicron variant, Madam Chair.
Dr. Clement, before you answer yung question ni Kong Kaloy, clarify ko lang, in-adapt ninyo yung policy ng Department of Health dito sa guidelines on the pricing ng testing, right?
I'm sure yes.
Oo, doon sa guidelines nila, may penalty tayo for those facilities not following the price cap.
Meron po.
Dito kasi sa inyong circular, wala kayong nakalagay na penalty. So, ibig sabihin, the accredited facilities are expected to follow the price cap. So, walang over and above, and which means wala dapat out of pocket. So,
Yes.
if that's the case, no, kung nag-over ka doon sa 2,800 based doon sa qualifications or eligibility that you mentioned, ang penalty niyan is suspension or revocation of license. Tama? Yung conditions for payment ninyo, kung comply nila tong condition for payment, and then yung price cap ninyo, let's say for COVID-19 T1, 2,800. If they charge more than 2,800, then they can be penalized.
Madam Chair, just checking po policy ng PhilHealth. I think we also provided here the penalty clause or the penalty clause po na such that all adverse monitoring findings regarding non-compliance to the provisions of that policy shall be validated and subjected to healthcare providers' performance assessment system without prejudice to filing of appropriate legal cases or legal action of this part.
Okay,
And,
so the question now, in relation doon sa question din ni Kong Kaloy, how do you monitor and validate? Meron ba kayong monitoring team or validation team or kaya at least meron kayong mga hotlines for complaints ng ating mga beneficiaries or members?
Before I will answer that one, I would just like to clarify that there is an additional provision po dun sa policy namin that private facilities may charge co-payment only up to 20% of the full package rate and additional fee for home service based on the rates still again as prescribed by the applicable DOH guidelines. On the question naman po ng monitoring, we have naman po monitoring teams to check if they are following the rates of PhilHealth. And also we have an action center wherein they can, any member can complain, give us a feedback, and can provide us a complaint report para po ma-action ng PhilHealth.
Okay, so thank you, Madam Chair. If I may continue, Madam Chair, no? So, yeah, thank you, Madam Chair. So, ganun pala yung policy ngayon talaga ng PhilHealth, no? Yung dinagdag kasi ng ating resource person, allowed pala, despite the cap of 2,800, pinapayagan nila yung mga accredited providers nila to charge additional 20%.
40%?
20%, Madam Chair. Kaya yung lumalabas ngayon sa private, talagang ang rates nila, no, umaabot sa 3,360, and that's an additional 20% doon sa 2,800. Kaya talagang yun ang sinusunod ng mga private accredited, no, to ensure that our members ay may co-payment. Instead of the 2,800, talagang sinisingil pa rin yung ating mga members ng additional 20%. Kaya umaabot yung private accredited laboratories, ang rates nila nasa 3,360. No? Dahil nasa policy rin ng PhilHealth. I think it should be reviewed by PhilHealth. No? Kung kinover, bakit kung pwede namang 2,800, bakit kailangan mag-charge pa ng additional 20%? Otherwise, i-cover na lahat ng PhilHealth yung 3,360. No? Dahil previously, ang kino-cover naman ng PhilHealth is nasa 3,409. No? Kaya I'm really wondering, Madam Chair, no, itong bagong rates nila. If you want to bigyan talaga natin ng mabilisan at matulungan ng ating mga kababayan, kung ano yung sinabi nating rates, that's 2,800, then that's 2,800. Huwag na nating abalahin pa ang ating mga miyembro na dumukot pa sa kanilang bulsa dahil sa policy ng PhilHealth pinapayagan pa magdagdag ng 20%, no, as copay rate ng ating mga members. So that's one issue na gusto kong i-address ng PhilHealth, Madam Chair, bago natin bitawan ito dahil as it is nga ngayon, ang pinakamalaking usapin ay maliban doon sa rollout ng bakuna ay itong paano natin matest ng matest ang ating mga dumadaming infected or suspected na infected na kababayan. Last na siguro, Madam Chair, no? I want to hear a reply on that issue. Then last question ko na, Madam Chair, I think September 2021 pa, in-approve na ng HSTAC, no? Yung paggamit ng antigen testing. Now, meron na bang policy? I don't know if it was already asked previously. Kailan maglalabas ng guidelines or policy ang PhilHealth to cover as well, no, yung cost ng antigen test ng ating mga members, Madam Chair?
Dr. Clement.
Currently po may proposal po na ilalakad na po sa board namin to cover or to consider antigen test in confirming or determining whether the patient has a COVID-19 or not. So that kung positive po sila for antigen test, then they could avail of the COVID benefit package. But then this does not mean that we will have we will have a separate package for payment or coverage ng antigen test itself. So sa ngayon po, yung policy direction is to just consider it as one of the tests to determine whether the patient has COVID-19 or not, and then they can avail the COVID-19 package. Tapos po, moving forward, we are still studying the rates that will be used or to cover the antigen test itself.
Thank you, Madam Chair. Moving forward, kasi September 2021 pa in-approve ng HSTAC yan, ano? And nasa 33,000 na yung infected as of yesterday. And probably today, mas tataas uli. How soon that can the board, PhilHealth board, finalize this, no? Para naman ang ating mga kababayan, kung talagang approve na itong antigen test na ito at malaman na natin kung magkano yung sasagutin ng PhilHealth, they can easily or immediately avail of this antigen testing kung hindi available yung RT-PCR testing, Madam Chair. Can we get a clear timeline from PhilHealth? Kasi baka nababala tayo rito sa yung bureaucratic processes, no, na pag-uusapan pa, pag-aaralan, isa-submit sa board. By that time siguro ma-approve ng board ito ay baka meron na namang variant, no, na mas matindi pa. Wag naman sana, no, pero yun ang sinasabi ko, Madam Chair, mabilisan sana ang ating pagtugon sa mga problemang ito, Madam Chair. May we get a reply from PhilHealth, Madam Chair?
President Garan, I guess, how fast can the board act on this proposal? President, Attorney Garan.
Pero may board tayo bukas. Tomorrow we will be having our board meeting. Now, we will assure this body, this committee, Mr. Chair, on the question of Congressman Caloy Sarate. The next board meeting after tomorrow, we shall discuss this in the board meeting. Thank you.
So did I get it right, Madam Chair, that the board's meeting will be tomorrow?
No, tomorrow there will be a meeting for the board, but the next board after tomorrow, we will discuss this matter with the board.
Ay bakit kailangan pang paabutin, Madam Chair, sa next meeting ng board, no? May I suggest that tomorrow's board meeting, this issue on antigen testing should already be included kahit doon sa other matters siguro, Madam Chair, kung meron na silang set of agenda to be taken tomorrow. May we May we suggest that, and will the PhilHealth consider that? Napaka-importante po ng issue na ito, no? Sabi ko nga, exponential yung spike, at ang ating mga kababayan gustong magpa-test, hindi nila alam ngayon, is antigen test covered by PhilHealth dahil RT-PCR lang yung current natin na kino-cover. But if the board can already decide tomorrow, kasi may meeting naman pala ang board, pwede naman siguro, Madam Chair, if we suggest strongly to include this in the other matters, no? Para mapagdesisyonan na rin. Can we get a reply? May we get a reply from President Geran, Madam Chair?
President.
Madam Chair, before a matter is to be tackled in the board meeting, there are preparations to be made. There are documents to be made. Before the submissions will have to be accepted by the board. But because of a good friend from Davao, we will force the issue tomorrow to be discussed sa board on emergency matter. Thank you po.
Thank you, Attorney Garan. Kindly provide the committee on the updates of what transpired during your committee board meeting. Kong Kaloy, can I call on the next interpellator?
Yes, Madam. Thank you, Madam Chair, for the time. Thank you, President Geran, and to our resource.
Thank you. Before I call on Kong Stella Quimbo again, I would like to ask first yung ARTA kay Secretary Belheca. Is still, nandito pa ba?
Yes, ma'am. Yes, Madam Chair.
Yes po. Sir, you mentioned earlier one of your recommendations sa PhilHealth on payments, no, to fast track yung payments natin. If beyond 60 days, which is supposed to be the maximum number of days na dapat na process nila at nabayadan yung claims, they should pay 100%. Tama po ba?
Yes, Madam Chair. That is our recommendation. Tama po yan, Madam Chair.
So, can we ask Attorney Geran, ano po ang action na ginawa ng PhilHealth doon sa recommendation ng ARTA? Kasi yun pa rin yung problema natin. Kanina, nire-reiterate ni Kong Stella na based doon sa inyong presentation, majority of the claims ay beyond 60 days. Doon sa presentation ninyo, ilang percent yata yan? 51% I think, yung beyond 60 days. So, since may recommendation po ang ARTA, ano po ang plano ng PhilHealth?
Chair, we shall stick to our commitment made earlier. The 25.45 billion will have to be liquidated. Will have to be paid in 6 months' time.
Okay, thank you so much, Attorney Garan. We'll be expecting na magkakaroon po ng magandang performance, no, in the coming months ang PhilHealth, and yung ating mga hospitals will be prevented from disengaging from the accreditation. Kong Stella?
Yes, Madam Chair. Before I ask my question, I would just like to clarify with Dr. Almora kung ano yung naging findings ng Congress with respect to case rates. Hindi po, if you read the committee report, ang naging criticism ng Kongreso sa case rate system is that according to PhilHealth, 22% are overpayments, 78% are underpayments, in which case 0% correctly set. In other words, mali-mali ang pag-set ng case rate. Bakit? Because the case rates are based on average value of claims. It's not based on the actual cost of care. So yun ang naging criticism ng Congress. Ang sabi namin, case rates are good because may efficiency gains, as you were explaining earlier. However, PhilHealth gives case rates a bad name because of how they are implementing it. So hindi kami against the case rates. Hindi kami ang dahilan kung bakit bumalik sa fee-for-service. So yun lang po, just a clarification lang po. Hindi po, I don't think nakasalanan ng Kongreso kung bakit napunta sa ganyang sitwasyon ngayon. But anyway, meron namang commitment na pag-aralan ulit na ayusin yung confusion dito sa fee-for-service at case rates. My question, Madam Chair, again, nakaka-disappoint dahil ni-reiterate nyo na nga po, Madam Chair, at ng ARTA na 60 days lang talaga ayon sa batas ang limit sa pagbayad ng claims. Sinabi ni Presidente Yeran na talagang 6 months pa daw ang kailangan. So the question is, ano ba talaga ang weakest link? So napag-usapan na kanina yung manpower, yung 900 plus na katao with 30,000 claims per day. Parang if you divide those figures, parang lumalabas 30 claims per person lang eh. So parang per day. At sa tingin ko, dahil electronic na yung system, kayang-kaya yun eh. Dahil magagaling ang mga claims staff ng PhilHealth. So ang tanong ko, baka naman ang weakest link is the IT system. So nagda-down ba ang IT system natin? Gaano kadalas ma-down ang IT system? How many days in 2021 na-down ang IT system para sa claims? Maybe we can ask, I'm not sure if si VP Waway ang in charge sa operations. That's what he said earlier. Baka VP Waway can answer that.
Madam Chair, Kong Stella, totoo po, I think one of the weakest link talaga natin yung IT. That's why we need to solve that. But we are very thankful for Congress, both Senate and HOR, because nag-grant na po yung 7.5% for the budget. That means we can now actually fix our manpower problem, o may pag-asa na ma-fix ang manpower problem and the IT system. But we need to work on that. But let me say po, hindi ko po nabilang eh, but totoo po that we are experiencing a lot of times na down po ang system. But I think we are monitoring it sa IT. May I ask her, ma'am, si Doc Art Alcantara po ata, meron siyang data on that, Madam Chair, Constella.
Doc Art?
Thank you po, Madam Chair. No? Actually, nagkaroon po kami ng mga downtime since October. No? Ito po yung mga months po na nagkaroon po ng spike po or increase in the submission of the claims. And so nagkaroon po ng mga increase in the high utilization po ng IT resources. No? So tinamaan po yung mga ibang aming servers. No? So we were able to get the support and kasi naka-warranty po yung aming mga servers. But then po, hindi po kinaya ng local partners, so tinawag na po yung mga international partners. No? Kaya lang po, we were not able to apply po yung mga fixes because of course, marami maapektuhan po yung operations namin, pero we were able to do that during the holidays. So na-fix na po yung mga problems po during the holidays and okay na po ngayon. Yun lang po.
Madam Chair, simple lang yung question ko. No? Sa buong 2021, ano yung total number of hours or days na naka-down yung system? Kasi electronic lahat yun eh. So kung mag-down yung system, may logs yung system as to ano yung total number of days or hours na naka-down yung system.
Yes po,
so yun po yung tanong.
Based po dun sa mga monitoring namin dun sa IT resources po, no? Actually 30 minutes to 1 hour po in a day po. Pero not po every day po, no? Siguro in a week po, mga 1 or 2 times a week po. Yun po yung, yung mga experiences namin yung monitoring po.
Pwede niyo po bang isubmit na lang sa amin din yung exact number? Because again, dapat yan ma-generate kasi electronically, automatic po ang pag-generate ng information na yun sa isang electronic system, di po ba? So isubmit niyo na lang po sa amin. And number 2, katulad na nabanggit ni VP Waway na madalas mangyari nga na down ng system, talaga bang ayaw ninyong i-outsource habang pino-procure nyo pa yung panibagong IT system? Because as we know, ang hirap mag-procure sa gobyerno. Nagkaroon nga kayo ng problema noong 2020 sa pag-procure ng IT system. We anticipate that those procurement issues will not go away. Are you open to the possibility or to the idea na i-outsource na talaga ang mismong pag-electronically process ng claims?
before Sir Waway respond, Kong Stella, if I remember it correctly, since 16th Congress, no, when I started sa Congress as member of this committee, and then I was the chair last Congress then, we've recommended na that to PhilHealth, no, kasi nakita na namin over the decade, yun talaga ang pressing problem at this mga previous years natin. At palaging yan din ang nire-reason ng PhilHealth. And we ask nga, how confident ba sila doon sa mismong IT people nila in developing their own system? Kasi it seems na pabalik-balik yung problem. So it's good na, okay, napag-usapan again natin. Pero it seems na parang hindi sila open talaga into getting an outsourced service or third-party service. So siguro Sir Waway, ano ba talaga ang gusto pa rin pa talaga ninyo na kayo talaga ang nagpipilit na solve ditong problem na ito na ilang dekada na hindi pa rin po nasosolve?
Opo. Yes, Madam Chair, Kong Stella. Actually, under the direction of President Giran, we have formed a task force, tawag namin doon, Task Force IT, to find another option to fix the IT. Tama po kayo. I think instead of fixing it, mas maganda siguro come up with a new system. The root cause kasi, Madam Chair and Kong Stella, is yung mga developers natin since 1999, palaging mabilis yung turnaround. Mas mabilis sa turnaround ng claims sa PhilHealth. Kasi pinapirate po sila sa ng ibang mga companies, no? Because of the low salaries ng PhilHealth. In fact, pasalamat kami kay President Duterte na yung EO 150 is now here to fix the salary system kasi dapat ipantay lang yung salary ng taga PhilHealth with the other agencies. So, but that's another topic. And pasalamat din kami sa Senate and House of Reps for giving us the budget, no, para makabili na tayo ng and finally we can fix the manpower problem. But we are exploring generally three directions. Number one is the development, outsourced development, government agency to government agency arrangement. Kasi ako nandyan po din ako sa task force na yan. Kaya medyo phobia ako doon sa mga private. So government agency to government agency. Number two, we are exploring yung malalaking private agencies like corporations like Microsoft and Google. And number three po, naumpisahan na po yung option of asking for a system country-to-country arrangement. So nakapag-usap na po kami with the Korean ambassador kasi yun ang nakita ko na medyo okay na system eh. So and we gave the committee until March po to be able to present to top management kung ano na po ang resulta. So yun po ang basic directions ng task force na yan, which is another option to look for solutions sa IT po. Over po, Madam Chair, Madam Stella.
And what is your deadline? What is your commitment? Anong petsa na magkakaroon ng specific or concrete action?
Opo, by March po, the end of March as our deadline po sa committee namin. And tulad nung sinabi ni Doc Art, it has to be within the year for implementation. So as usual, that will be end of 2022.
Abangan na lang natin yan, Madam
Opo,
Chair.
abangan
Salamat
natin.
po.
Opo.
Thank you, Kong Stella. Before we proceed to the discussion of House Bill 7429, I think Secretary Jeremiah Belheka is asking time for a brief presentation on their recommendation.
Thank you, Madam Chair. I promise to be very brief, Madam Chair. I know the importance. Baka lang makatulong, Madam Chair. I'll be sharing my slides. Can you see my slides now, ma'am?
Yes, please proceed, Sec.
Okay, so I will just give a quick overview, ma'am, of the findings and recommendation, and we will also be submitting this. We have thoroughly discussed this also, Madam Chair, with President Hiran and VP Waway and the entire team, which we are grateful also with the private sector, the PMA and the PHAPI, Madam Chair. Just to a quick review, Madam Chair, of what we can do. We are helping in the streamlining and giving recommendations on the processes of PhilHealth, and also some investigations, Madam Chair, on some deliberate findings if we have some complaints na pupunta po sa amin. Now, just an update, ARTA prepared a position paper containing our initial findings from the consultation meetings and corresponding recommendations to address the issues, challenges in processing of PhilHealth claims. This position paper was submitted to the office of Congressman Michael Edgar Aglipay as Chairperson of the House Representative Committee on Good Government and Public Accountability last September 2021. The same was also sent, Madam Chair, to the office of our good President Dante Hiran, and also the chairperson of PhilHealth, DOE Secretary Francisco Duque last September 9, 2021. And the paper was also later updated and transmitted to the office of Senator Eduardo Angara last December 16. And Madam Chair, we would also be furnishing your good office, ma'am, a copy of this recommendation and findings. So a quick snapshot, ma'am, is the initial findings was on the receiving of e-claims. Definitely, Madam Chair, there was a problematic internet connection and a lack of cloud storage, deficient IT infrastructure, and the recommendation was improvement of the IT infrastructure and cloud storage. We also assisted in tapping the ICT to help in this concern, particularly to use the temporary usage of the BIR cloud storage, Madam Chair, and I believe that they have been conversing directly. Also, on the RTH, Madam Chair, the return to hospital applications, normally the cause is either wrong diagnosis, maaring, Madam Chair, or faulty documentation. The recommendation is if it is a faulty documentation, streamline the pre-assessment or pre-payment review and implement instead, Madam Chair, a post-audit and an automated system. Ibig sabihin po, Madam Chair, kanina ho sa presentation ni Attorney Santos, ni VP, COO Santos po, a misty 5%, Madam Chair, is attributable to denied claims. So ibig sabihin po, 95%, except siguro yung return to hospital na another 5%, 90%, Madam Chair, ay talagang pumapasok at naaprubahan. So it might be better na magkaroon na lang ho sila ng post-audit system rather than magkaroon ho ng stringent na pre-payment review. Also, the medical prepayment review, in this streamlined process, PhilHealth shall only review the submitted documentary requirements, Madam Chair, and the conduct of medical assessment shall be done within the 60 days processing time given by their law. Yung kanina hong sinabi ng ating pong PMA President, pwede hong i-apply yun, yung case rate, Madam Chair, in the paggamit po ng post-audit instead of a pre-payment review that is more stricter. Total ho, Madam Chair, ang nagpe-prepare po ng mga assessment evaluation sa ground ay mga doktor din, which also are licensed. So, moving forward, Madam Chair, on the issues on the debit credit payment method, I think this has been thoroughly been discussed, and also we thank the PhilHealth for pushing through with this, Madam Chair. Napansin ho namin that only for COVID-related instances lamang ang kanilang debit credit payment, but now they even expanded it to 80%. So we recommended na ito po ay i-implement na lang po sa lahat. So ibig sabihin, Madam Chair, baka pwede pag-submit ho ng documentary requirements, bayaran na ho agad ng 80%. So within that 60 days, meron na po silang makukuha, and then pag natapos po yung 60 days, Madam Chair, it could actually be paid in full. Or and after the full payment, then it could be subjected to post-audit, Madam Chair. On PhilHealth to devise a credit scoring system for hospitals and health institutions that shall serve as a basis for the prioritization of claims and releases. The scoring system should be based on the following criteria: historical records of good claims, amount of claims, capacity size of the healthcare facility, and also the continuous observance of the 60-day processing time. Ibig sabihin ho, Madam Chair, sa ngayon po, kung meron ho silang 10,000 na mga claimants or 5,000 na mga claimants, sino ho ang uunahin doon? So right now, it's a first in, first out mechanism. Kung saan maaaring maipit po yung mga more vulnerable institutions because they have lesser capacity to go on without these reimbursements. So a scoring system could actually be beneficial, Madam Chair, for this. So now on some special recommendations for legislation, Madam Chair, sinabi nga ho namin talaga sa PhilHealth, kapag ka masyadong mabilis po ang kanilang payment, although sa amin pong recommendation talaga sana gusto ho namin pag 60 days, bayaran na ho ng buo. Pero dahil ho sa mga nakalipas na mga investigation and cases that was filed, they are a lot of people in the regional offices on the ground are very careful in paying, nagre-result ho minsan sa tumatagal. So, a law, Madam Chair, may be passed mandating and authorizing PhilHealth to pay all claims complete with all documentary requirement that remains pending beyond 60 days, and the case rate shall apply in the payment. The legislation shall provide a legal cover in this case for PhilHealth that would allow payment within a period of 60 days and thereafter apply a post-audit method over a strict prepayment review. PhilHealth shall conduct a post-audit within a period of 6 months from payment of claims. So, Madam Chair, she will be submitting, ma'am, this is just, Madam Chair, some of the overview and a more thorough discussion will be submitted to the Chairperson. Thank you, ma'am.
Thank you, Sec. So very clear, no? Thank you. Maganda po yung recommendation nyo. Ang recommendation nyo on DCPM is 80% bayadan kaagad nila and wala nang pre-medical audit, no? Pero doon sa circular nila nakalagay is I think 60% and 40%, which is yung question natin, up to when yung 40% babayadan, no, ng PhilHealth. So I hope doon sa commitment ni President Geran, they will consider yung recommendations of ARTA, no? And if you review doon sa UHC law, may basis po kayo para sa implementation. Nakalagay po doon ang global budget, whichever strategy would help doon sa access of the Filipinos to medical services, no? But also with safeguards doon sa spending of the PhilHealth funds, no? So I hope yung recommendation ng ARTA will be one of the consideration ng PhilHealth to meet yung target nyo na within 6 months, although yung 6 months po is not acceptable pa rin sa mga hospitals because financially draining na sila, mataas na ang kanilang financial exposure, out of pockets nila or yung cash flow nila talaga is affected because of this delays, return to hospital and denied claims, no? So maraming salamat po Secretary Jeremiah.
Salamat po, ma'am.
Okay.
Madam
Thank
Chair,
you so much po.
pasingit lang, Madam Chair, short lang.
Yes, Kongging.
Yes, Madam Chair, can we get may I suggest that we conduct a meeting to get kasi parang for sure i-consider to ng PhilHealth to get an update of the action taken by PhilHealth over the very good, brief pero precise and direct and nakuha talaga nila yung dapat gawin ng PhilHealth with regard to ARTA recommendation. Can we set a meeting, Madam Chair?
Sige, we'll conduct another hearing siguro next week, no? Sa resumption natin. We'll schedule another hearing to further discuss, no, ano yung mga actions undertaken. Especially we want then the COA sana on board kasi gusto din natin mag-comment sila doon sa recommendation naman ng ARTA. No, baka sasabihin na naman yung COA rulings natin kung yung recommendation is within that COA rulings. Yes, sir.
Thank you very much. Thank you very much, Madam Chair.
Yeah. Thank you, Madam Chair. Thank you, Kong Swansing. Ma'am, for the information of the body, there is an April 10, 2021 letter by Chairman Mike Aguinaldo of COA regarding the debit credit payment, Madam Chair. Doon po, Madam Chair, it was stated actually that there is really no prohibition for them to apply it because it's an internal policy. Nandun nga ho, as mentioned by Congresswoman Stella kanina, na nasa implementation po talaga, minsan nagkakatalo. But just for the information of the body, we also invited COA, ma'am, in some of the meetings that we had. So we'll also be submitting this, ma'am. We'll incorporating this in our report po.
Okay, thank you so much, Seth. I think we can now proceed to the initial deliberation of House Bill 7429, authored by Representative Stella Luz Quimbo. Kong Stella.
Yes, Madam Chair, for my sponsorship. Madam Chair, sa pagdating ng Omicron, may panibagong surge na naman in COVID cases. Kahapon, meron tayong lagpas 33,000 COVID cases. At hanggat merong COVID at may problemang pangkalusugan, nananatili pong mahalaga ang mandato ng PhilHealth. Kung walang PhilHealth, baka hindi na magpatingin sa doktor ang mga may sakit. Kung walang PhilHealth, mas lalala pa ang kawalan ng access to healthcare. Ayon sa Philippine Statistics Authority, for every 10 Filipinos who die, 6 are not medically attended or 6 die without seeing a doctor. Hindi na sila nabigyan ng pagkakataon na ipaglaban ang buhay nila. Titindi pa ito kapag lalong humina ang PhilHealth. I filed House Bill number 7429 in August 2020 amidst congressional investigations on PhilHealth issues, including the anomalous disbursement of IRM funds, fraudulent claims, other allegations of corruption, and the ineffective implementation of the case rate system. Around that time, 13 key officials of PhilHealth were put on preventive suspension, while 3 senior officials, including the president and CEO of PhilHealth, tendered their resignation. On October 29, 2020, another 8 PhilHealth officials were suspended in connection with the alleged irregular release of IRM funds. And then again, an additional 3 PhilHealth officials were suspended on November 10, 2020 in connection with an anomalous ID project. So all of these suspensions and resignations, Madam Chair, raised the concern of a management vacuum within the PhilHealth. Last December 2021, COA released its 2020 report on PhilHealth and validated some of the important findings of Congress, including the unnecessary excessive releases of IRM funds. Buti na lang, as early as August 2020, alam na natin dito sa Kongreso na maraming problema ang IRM system, kaya't nirekomenda na natin ang pagtigil nito. Last May 2021, I filed another resolution to investigate the alleged failure of PhilHealth to pay hospitals their benefit claims. These payment failures caused liquidity problems for some private hospitals that ultimately caused the reduction in capacity and manpower. And all of these happened at the height of the Delta variant surge, when maximum hospital capacity was of utmost importance. Mula January 2020 hanggat August 2021, umabot sa 21.1 billion pesos ang unpaid claims ng PhilHealth. And during the 2 hearings of the Committee on Good Government and Public Accountability on my resolution, and this were held in August and September 2021, PhilHealth President Iran assured Congress that payments would be made as soon as possible. Subalit, noong December 2021, nagbanta na naman ang ilang mga ospital na mag-disengage sa PhilHealth dahil sa ulit unpaid claims. Hospitals from Metro Manila, Cagayan Valley, Iloilo, and General Santos City were planning to disengage from PhilHealth. FEU and RMF declared their intention to disengage with PhilHealth after incurring more than 200 million in unpaid claims. 7 private hospitals in Iloilo also signified the same intention due to total unpaid claims amounting to 895 million pesos. In 2 In two Committee on Health hearings last year, it appeared that PhilHealth had overly complicated their claims processing procedures and became unreasonably strict in their payment of hospitals. Tila hirap ang PhilHealth na balansehin ang dalawang layunin ng fiscal prudence o pangangalaga ng pondo at access to healthcare o yung paninigurado na merong sapat na ospital at doktor pag nagkakasakit ang mga kababayan natin. Madam Chair, matagal na tayong may krisis sa PhilHealth. Nandiyan ang corruption allegations, nandiyan ang COA findings ng misuse of funds. Nandiyan ang paulit-ulit na pagbanta ng mga ospital na mag-disengage sa PhilHealth. Ang ibig sabihin ng private hospital disengagement, paggagamit tayo ng private hospital, wala na tayong suportang makukuha mula sa PhilHealth at the point of hospital discharge. So in other words, bahala na tayong mag-directly collect from PhilHealth. So malilipat na ngayon yung burden ng delay in payments sa atin, mga miyembro, sa halip ng ospital. Baka naman ang ending, wala nang magpo-ospital. At taon-taon, tuwing budget hearings, ang PhilHealth na mismo ang paulit-ulit na nagsasabing malulugi na sila, na matatapos na ang actuarial life nito. Pero dahil sa bigat ng mandato ng PhilHealth, natulungan ang bawat Pilipinong may sakit na bayaran ang kanilang medical bills, we need a permanent solution to the PhilHealth mismanagement problem. Hindi pwedeng band-aid solution tuwing nagdudugo ang mga sugat ng PhilHealth dahil sa totoo lamang, dumadalas na ito. Hindi na pwedeng tinatawag ng Kongreso ang PhilHealth tuwing may problema at magpropromise ang PhilHealth ng action, pero kalimitan ang ending, broken promises. Madam Chair, I filed House Bill 7429 to help PhilHealth help itself. First and foremost, the bill recognizes the existence of a management crisis. It grants the President the power to outsource certain services from the private sector to operate segments of PhilHealth for increased efficiency. Due to better access to resources and technology, the private sector can perform certain functions in health insurance better than government. Subok na ang legal, IT, and actuarial expertise ng private sector. Hence, it is wise to tap into this pool of experts. At liinawin ko, Madam Chair, ang layunin ng House Bill ko ay i-allow ang outsourcing from the private sector. Hindi ito katumbas sa pagpa-privatize ng National Health Insurance Program, which is a social health insurance program and should always remain a government program receiving subsidies for the indigent households who cannot afford to pay insurance premiums. It cannot be private. It cannot be for purposes of profit generation. Ang sinasabi ko lang ay mag-hire ng eksperto mula sa private sector kung kinakailangan. The bill creates an executive legislative commission that shall set the framework for PhilHealth reforms. The commission can authorize to designate a transition management team from the private sector to lead PhilHealth in the interim. Marami ang talented individuals mula sa top management ng private health insurance companies. Pero sa tingin ko, baka kakaunti lamang ang gustong mag-apply sa PhilHealth management positions dahil sa tindi ng problema dito at dahil mas mababa ang sweldo. Kaya't panahon na para payagan ang pagkontrata ng buong management team on a temporary basis para ayusin ang sistema at i-train ang mga empleyado. The team will undertake reforms in PhilHealth like audits, policy reforms, and improve data and actuarial analysis and fund management. So, Madam Chair, my bill will not resolve all PhilHealth problems, but I believe that it is a necessary first step towards substantive reforms. Maraming salamat po, Madam Chair, for the opportunity to sponsor this measure. Salamat po for taking this up today.
Thank you, Kong Stella, for filing that bill. As I mentioned earlier in my opening remarks, I think it's worth our time naman na maging proactive with all the problems that we are encountering in PhilHealth, no? So we'd like to hear first from PhilHealth President Attorney Geran, on their position to this proposal. President Geran, you have the floor.
Thank you, Madam Chair. Good afternoon to all of us. Your Honors, We thank you for giving us the opportunity to express our position on House Bill number 7429, which seeks to grant President the power to privatize functions and take related measures for efficient provision of social health insurance services. The bill also seeks to reorganize PhilHealth under the auspices of an executive legislative commission, which will in turn designate a transition management team from the private sector to assume management of the corporation until its reorganization. May we respectfully inform the body that we have submitted our full comment and position paper on the proposed bill for the consideration and appropriate action of the Honorable Committee. Your Honors, allow us to thank the Honorable Stella Quimbo for taking the time to improve the current organizational setup of PhilHealth. However, may we respectfully point out that reorganization of PhilHealth is already mandated under Republic Act number 11223 or the Universal Healthcare Law. In fact, PhilHealth is already in the process of reorganization as directed by the Governance Commission for GOCCs or GCG. It is now in the final leg of formulating an ideal structure and staffing that will better respond to the needs of our 110 million beneficiaries. The proposal developed by management is guided by GCG's Memorandum Circular number 2015-04 regarding reorganization, rationalization, and personal planning in the GOCC sector. It will then be submitted to the PhilHealth Board for scrutiny, then to the GCG for review and approval. The GCG has already introduced refinements in the organizational setup and functional dimension of two critical offices at PhilHealth, namely the Office of the Actuary and the Arbitration Office, while it is also directed us to reconfigure our information and communication technology, ICT, infrastructure with the possible adoption of a private-public partnership, PPP, on some of the services. Example, claims and benefits payments. Your Honor, all these initial efforts as well as the impending reorganization of the entire corporation are considered or consistent with the proposal or the proposed bill's intention and have already gained momentum as no less than our PhilHealth Board intends this to happen the soonest time possible. Your Honors, this brings me to my second point. We believe that the creation of a joint commission may no longer be necessary as the proponent herself recognized the oversight function of both chambers of Congress as expressly provided for in Chapter 11, Section 39 of Republic Act 11223. There exists a joint Congressional Oversight Committee on UHC that conducts regular review of the implementation of the law and vested with the power to systematically evaluate the performance of the various agencies involved in realizing UHC, particularly with respect to the rules and functions. May I also respectfully inform this committee that the Department Secretaries of DOH, DOF, DSWD, and DOLI are already part of the Board of Directors of the PhilHealth, who are always on hand to assist and support the Joint Congressional Oversight Committee in making sure that the PhilHealth organization remains attuned to the needs and demands of its clientele. And then, of course, there is the GCG that, by virtue of its mandate under Public Act number 10149, exercises jurisdiction over GOCCs like PhilHealth. The GCG has the mandate and powers to ascertain whether a GOCC should be reorganize, merge, streamline, abolish, or privatize. On the transition management team that will be contracted from a private corporation or a management consultancy firm and to be designated by the proposed crisis commission to manage the corporation until the contemplated reorganization is completed. Such proposal is assailable and with due respect and susceptible to a lot of questions. The said transition team are composed of private individuals and not public officers. If permitted, the contracts that they will enter into, as well as their exercise of control and supervision over regular employees, may be in violation of pertinent laws. May we then express categorically that this legislative intent to address the various issues confronting PhilHealth can be properly done by way of an executive file. In explanatory note, the primordial intention of the proposed legislation is, quote, the need for a massive overhaul of the current system through the reorganization and privatization of PhilHealth, unquote. Your Honors, these things can be realized this year or in the early part of calendar year 2023 if the GCG will be directed by the President to fast-track the contemplated restructuring and or privatization of some segments of the PhilHealth and the procurement of a management consultancy firm, the prohibition on the issuance of appointments, among others. In closing, we want nothing but to serve the Filipino in the years ahead with healthcare benefits and services that are of quality, accessible, and affordable as mandated by universal healthcare law. We continue to call for your support, ma'am, and Congress, and join everyone to help PhilHealth be the program that we aim and envision it to be. Magandang umaga po at maraming salamat po sa atin lahat. Over.
Thank you, Attorney Garan. I would like to call on representative from the Department of Health. I think Yusek Mario Villaverde will represent Secretary Duque. Do we have Yusek? Yusek Mario?
Yes, Madam Chairperson. Magandang hapon po sa ating lahat at Happy New Year to all the members of the Committee on Health and our partners from the PhilHealth and the private sectors who are attending here. At the moment, Madam Chairperson, wala pa po kaming official position paper dito sa bill na pinail ng ating Stella Luz Quimbo, House Bill 7429, but I have made some notes. This was referred to me last night, and I read the bill thoroughly, and I will just make some clarifications and comments on how best to go with this particular House bill. As I have read from the explanatory note, and I will be discussing this with the Secretary of Health and the rest of the EXICOM, so that within the next week we will be able to come up with the official position of the Department of Health. But as read from the explanatory note, the main purpose of this House bill is the reorganization and the privatization of certain or all segments of PhilHealth. And this is due to the failure of leadership and the lack of technical expertise at the helm as a major root cause, but these are brought about, and this has brought about gross mismanagement of public funds and the pervasive systemic fraud within PhilHealth. Now, there are three key strategies that we can call out from the bill. The first one is granting the president the power to privatize any or all segments of PhilHealth. The creation of an executive legislative commission to design policy framework and steps to reorganize PhilHealth. And the third key strategy is the designation of a transition management team through some form of competitive selection and assume the management of PhilHealth until the reorganization and transition towards effective privatization of certain segments. Now, from this, we would like to point out certain areas of the bill. Like, for example, the first one is the clarification and delineation of roles between the Executive Legislative Commission and the Transition Management Team. I have noted that there are some similar functions, like, for example, in the crafting of policies, guidelines, and procedure, there must be some clear delineation of what level of policy will the Executive Legislative Commission do and what will the Transition Management Team will do. This is actually in Section 4, Section 4B and Section 6D of the proposed bill. The next concern here is in terms of the conduct of research and the gathering of information, as well as the contracting with private or public entities. This should be clarified in terms of the roles of the Executive Legislative Commission and the Transition Management Team. The second point that I would like to point out is when it comes to the contracting of the Transition Management Team. Some clarification on whether this will be on an individual basis based on individual expertise versus contracting an entire management consultancy firm. No? And then, of course, the issue of conflict of interest because we will be engaging private firms that are involved in health insurance. There might be some form of conflict of interest between the social health insurance as well as the private health insurance. So there must be some form of safeguard in terms of this conflict of interest. Then the second point here is the accountability mechanism of the private either private expert as individual or as a member of the consultancy firm. There should be a very clear accountability mechanism, and I think that Attorney Giran also made mention in relation to the accountability of a private firm or a private individual in relation to the accountability by public officers or staff. No? So there must be some clarification on this. So how we will manage conflict of interest as well as the accountability mechanism. Now, the third major point that I would like to mention is in terms of the privatization of any or all segments. This concern most specifically, and I think that earlier in the sponsorship speech of Kong Stella, she actually mentioned naman na itong related sa aking i-mention, yung concern related to the profit motive of a private entity versus the concept of a social health insurance. But I think that this was already mentioned by Kong Stella in the sponsorship. But there should be some form of a regulatory provision regarding this, some form of a safeguard in terms of the profit. no? Because we know that if we have some private entities managing certain segments or the entire PhilHealth, there will be some form of, return of investment for this. But there must be some form of control so that hindi naman po out of this world yung kanilang parang return of investment. And then the fourth aspect is in terms of yung na-mention po doon sa bill, yung upgrading of compensation of personnel. I think that this is a very good proposal. But the basis here is yung commensurate with improved and efficient revenue collection of the agency. But here, we would like to possibly see also that this improved or upgraded compensation should also be tied up, not only in terms of improving revenue collection, but in terms of improving the benefits for the members, as well as yung improving yung access and utilization by the members, and eventually in terms of the main objective of a social health insurance, yung reduction of the out-of-pocket expenditure of members, no? So hindi lang po yung efficiency and improved revenue collection, but also in terms of improving the benefits, the utilization, as well as the reduction of the out-of-pocket. And lastly, yung point namin, which I think most of which have been mentioned by Attorney Giran, yung reconciliation with the provisions and intent of the Universal Healthcare Act. There are certain provisions in the Universal Healthcare Act that we can actually use already in terms of improving the services, as well as the management and the processes and systems of PhilHealth, no? But we must look into this so that there will not be any duplication of certain aspects of the proposed bill, as well as what has already been enacted through the Universal Healthcare Act, as well as reconciliation also with the current initiatives of PhilHealth. There are already some initiatives and startup being made by PhilHealth to improve their policies, their systems, and their processes. So we have to look into this. Now, of course, Madam Chairperson and the honorable sponsor or author of this bill, the DOH will eventually submit siguro by next week yung official position paper. But these are just taken from my notes which I did last night when this was referred to me by Secretary Duque. So yun lang po, Madam Chairperson, and thank you to our sponsor, Representative Stella Quimbo.
Thank you, Mario. Kung Stella, will finish first all the resource person before you respond, no? May I call on, we have, I think, guest from Dole. Do we have guests from Dole?
Yes, Madam Chair.
Your position, ma'am?
Good afternoon, Madam Chair and the other honorable members of the Committee on Health. I am Stella Banawis, the Executive Director of the Employees Compensation Commission. I was asked by Dole to articulate the position of ECC and Dole for that matter on the House Bill, which is 7429, which is a very timely bill from our author, Congresswoman Quimbo. The ECC and Dole for that matter finds no conflict between the provisions of House Bill 7429 and the provisions of PD 626 as amended, or the Employees Compensation and State Insurance Fund law, which also provides for medical benefits for workers who are who meet work-related injury, diseases, or death. Now, the benefits provided under PD 626 will not be diminished by the proposed House bill, nor will the processing of the said benefits be affected. The DOL is one of the core group members of a group which is working on the establishment of the social protection floor for the Philippines. And the social protection floor is a strategy or an approach that will ensure that all Filipino citizens have basic social protection. One of the recommendations under this is to ensure that the universal healthcare law is implemented based on the timeline or roadmap on this. And one of the guarantees under that social protection floor is the guarantee that all citizens have access to essential health care, including maternity care. And if this bill will help in achieving the objectives of the UHC law, then we are amenable to such measure. The DOL recognizes the great importance of social health insurance in the lives of Filipino workers and the Filipino people as a whole. We further suggest, however, that the spirit of social dialogue, which DOL promotes, be embraced by whatever team or commission that will be created. And in pursuing their functions, they can get tripartite inputs in information getting and also in preparing their recommendations to for the transition of PhilHealth to a better organization. We take note also that the HB is not promoting privatization of PhilHealth, but to outsource some or most of its functions, and we are amenable to that because most organizations now are already outsourcing many of its functions to the private sector. Yan lang po, Madam Chairman, at maraming salamat po.
Thank you so much. We'll now call on representative from the SWD.
Good afternoon, everyone. Good afternoon, Madam Chair. This is Attorney Ongoko from the Program Management Bureau of the Department of Social Welfare and Development. As an update to the committee, we would like to inform the body that this bill is under the review of our department's legal service and the Policy Development and Plans Bureau. However, today I would just like to point out that we really appreciate that the DSWD was made or was proposed to be a member of the Joint Executive Legislative Social Health Insurance Crisis Commission, so that the DSWD will be able to give inputs in the enhancement or the reorganization of the PIC, as well as in securing any other reforms that we intend to be adopted in any formulations of policies or issuances regarding insurance policies. So that's the initial update from the DSWD, but we will be giving our formal position paper po, probably by the end of January or as early as possible. Thank you, Madam Chair.
Thank you so much, ma'am. Do we have guests from GCG?
Yes, ma'am. Madam Chair, good afternoon. Good afternoon. This is Attorney Morsha from the GCG. And again, good afternoon, everyone. Our formal comments is already with our principals and awaiting their signature and review. And right now, I have the substantial portions of the comments. At the outset, the GCG manifests its support on the initiatives of Congress to address the current health insurance crisis, especially now that COVID-19 cases are once again rising. So in terms of House Bill number 7429, our comments revolve around Section 8 thereof, particularly the executive leadership and the privatization of PhilHealth. Considering the mandate of the GCG under Republic Act number 10149, and as already mentioned also by Attorney Geran, first and foremost, sa selection po ng sa executive leadership, we may be able to assist by invoking Section 3B of RA number 10149 when it comes to the appointive directors po. They must be shortlisted first by the GCG and eventually approved for appointment by the President of the Philippines, and they must be able to meet the fit and proper rule for to become members of the governing board of PhilHealth. Next would be the privatization of PhilHealth. It was already cleared by the Honorable Stella Luz Quimbo that it is not a privatization per se na mapa-privatize yung certain segments. That is very clear naman po sa amin, and thank you for that clarification. And again, the GCG will be able to assist in terms of how to evaluate the performance and determine the relevance of the GCG to assert the GOCC, sorry, to ascertain whether such GOCC should be reorganized, merged, streamlined, abolished, or privatized. Nabanggit nga rin po ni Attorney Geran yun. And the GCG may be able to assist in that matter. So yun po, upon the signing of our principals of the formal comments, we'll be able to submit it na po. Thank you, Madam Chair. Yun lamang po.
Thank you, Attorney Morsha. Do we have guests from the Department of Finance?
Good afternoon, Madam Chair. This is Julie Bato, Division Chief from the Office of Policy Research. Presently, we are drafting the DOF position paper on the bill, and we shall immediately submit them to the committee once officially cleared. Thank you, Madam Chair.
Thank you, Ma'am Julie. Any representative from the Office of the Executive Secretary? Ma'am Sylvia, do we have a guest?
Wala po, ma'am.
Okay. We'll now call on Dr. Almora on the position of Philippine Hospital Association.
Good morning, Madam Chair and members of the committee. The Philippine Hospital Association Board of Directors and its membership did not have sufficient time to discuss fully the different provisions of the bill. However, we had time to identify some important matters that we should share to the author of the bill that may help in the improvement of the bill. Madam Chair, the Philippine Hospital Association expresses its appreciation to Congressman Stella Quimbo for her effort to find solution to the health insurance crisis through House Bill 7429. With your kind indulgence, kindly allow the Philippine Hospital Association to relay its thoughts on the matter of the privatization of health as a solution to the problems in healthcare created by PhilHealth. We agree that there is a need to reorganize PhilHealth. However, we humbly propose that the reorganization should primarily be focused on reorganizing the policy-making body of PhilHealth, which is the Board of Directors. It has been observed by our membership, which PHA has brought up in different fora, that the present Board of PhilHealth is overwhelmingly dominated by experts in finance and other matters, but no qualified representative. Sorry for that. But no qualified representation for healthcare institutions, healthcare professionals, and healthcare facilities in the services, except for the recent inclusion of a healthcare professional. With your kind indulgence, Madam Chair, may we point out that there is a failure to implement the provisions of Section 13 and Section 14 of the Universal Healthcare Law, which provides that in Section 13 refers to the PhilHealth Board of Directors, that the Section 13.1, the PhilHealth Board, hereinafter referred to as the board, is hereby reconstituted to have a maximum of 13 members consisting of the following: 13.1A, 5 ex officio members, namely Secretary of Health, Secretary of Social Welfare and Development, Secretary of Budget and Management, Secretary of Finance, and Secretary of Labor and Employment. 13.1B, 3 expert panel members with expertise in public health management, finance, and health economics. And 13.1C, 5 sectoral panel members representing the direct contributors, indirect contributors, employers group, and healthcare providers to be endorsed by the National Associations of Healthcare Institutions and Healthcare Professionals, and representatives of the elected local chief executive to be endorsed by the League of Provinces of the Philippines, League of Cities of the Philippines, and League of Municipalities of the Philippines. I would like to underline here and emphasize, Madam Chair, the provision that the healthcare provider representative is to be endorsed by the National Association of Healthcare Institutions and Healthcare Professionals, which we have not been able to do. And I would like to invite you further to the provision of 13.6, which states that all appointed members of the board shall be required to undergo training in healthcare financing, health systems costing, health services, and HTA prior to the start of their term. Non-compliance shall be a ground for dismissal. And 13.7, within 30 days following the effectivity of the Act, the Act took effect last November 22, 2019, and 30 days after the effectivity of the Act is December 22. The Governance Commission for the government-owned or controlled corporation shall, in accordance with the provisions of RA 10149 or the Government-Owned or Controlled Corporation Act, promulgate the nomination and selection process for appointed members of the board with a clear set of qualifications, credentials, and recommendations from the concerned sectors. And on Section 14, which is a section on President and Chief Executive Officer of PhilHealth. 14.1, upon the recommendation of the board, the President of the Philippines shall appoint the President and CEO of PhilHealth from the board's non-ex officio members, provided that the board cannot recommend the President and CEO of PhilHealth unless the member is a Filipino citizen, must have at least 7 years of experience in the field of public health, management, finance, and health economics, or a combination of any of these expertise. It is very clear, Mr. Chair, that there is failure to implement these provisions of the Universal Healthcare Law. We believe that the relative lack of hospital and medical expert representatives in the board is largely contributory to the creation of vague, confusing, and unfair and unreasonable policies applied during this pandemic. We propose that these provisions will first be implemented. In particular, we propose the following. Number one, the healthcare organizations be allowed to nominate the representative to the board, something that never happened since the start of the operation of PhilHealth. Number two, amendment of Section 13 of IRR of RA 11223 to create additional seats in the board to include representative from the diverse healthcare interests, namely private hospitals to be represented by the Private Hospital Association of the Philippines, government hospitals to be represented by the Philippine Hospital Association, healthcare medical professionals to be represented by the Philippine Medical Association. And number three, amendment of sections 9.4, 9.5, 9.6, and 9.7 of RA 11223 on no balance bill payment for the purpose of allowing private hospitals to charge from patient the balance of PhilHealth benefit package. This is in observance of the constitutional right against confiscation of private property and involuntary servitude. Number four, review the provisions of the procedures and rules on administrative cases for the purpose of amending it to ensure administration of due process to healthcare institutions and hospitals. This includes possible transfer of adjudication of administrative cases to an unbiased third party, such as the Insurance Commission or the GOCC. That's all for now, Madam Chair. The official position paper with further discussion on the provisions of the bill shall be transmitted later. Thank you, Madam Chair.
May we hear from the DBM?
Good afternoon, Madam Chair.
Yes, ma'am. Please proceed.
If I may read po, I'm Marilu Lagarde from Budget and Management Bureau C of the DBM. If I may read our initial position on the proposed bill, We would like to inform the committee that inasmuch as the issues posed on the said House bill will not entail additional premium subsidy support from the national government to the PhilHealth, we defer to the Governance Commission for GOCC or the GCG, as mentioned earlier, being the supervising agency of the PhilHealth, pursuant to Republic Act number 10149. Moreover po, Madam Chair, we also defer to the position of PhilHealth with regards to Section 7 of the proposed House Bill, wherein it is stated that funds necessary for the just compensation of the transition management team created under Section 4 therein shall be taken from the funds allotted for administrative expenses of the National Health Insurance Program as provided under Section 12 of the Universal Healthcare Act, inasmuch as the PhilHealth is the administrator of the said fund, Mr. Chair. That's all po.
Thank you. May we hear from Dr. De Grano? Is he still with us?
Yes po. Good afternoon, Madam Chair and Honorable Congresswoman Quimbo. The Private Hospitals Association want immediate resolution on the problems we are presently encountering with PhilHealth. And we agree with the Honorable Congresswoman on the problems within PhilHealth that seem to be the cause of the present difficulties that we are having right now. In general, if the bill and subsequent law will improve the present situation, we have no opposition to its implementation. We also expect the bill to resolve problems which are presently we are having with respect to some provisions of the Universal Healthcare Law, which we think are not favorable to the private hospitals, and which includes quasi-judicial powers given to the PhilHealth and which are causing our present situation. The PHA has mentioned those as given by Dr. Almora. With regard to the creation of the transition management team and reorganization of the PhilHealth, we will have a meeting with our board and members and will be submitting to the committee and to the Honorable Congresswoman our statement with regard to her proposed bill later. Thank you very much and good afternoon.
Thank you, Dr. De Grano. Do we have other guests who want to comment on the proposed bill?
May be allowed, no?
Yes, sir. You are from? Mr. Bringas, for a while po, we'll recognize first representative from MOPI, Dr. Carlos Da Silva.
Magandang araw sa inyong lahat. I've been filling up your chat box since this morning. Let me just summarize it by saying that we shall submit a position paper later this afternoon. However, on House Bill 7429, which is precisely aimed to address the social health insurance crisis the country is currently experiencing, we agree to its provisions and fully support the same, particularly on the following protocols. I have listed down 3. 1, address all the issues relevant to the social health insurance crisis, including the serious matter of graft and corruption in all agencies involved in the implementation of the National Health Insurance Program. 2, organize a joint executive legislative social health insurance crisis commission, which is critically important and absolutely needed. But if government is really serious in resolving the country's many issues with PhilHealth. And third and the last, for the Joint Executive Legislative Social Health Insurance Crisis Commission to regularly submit without fail, specifically based on a predetermined submission schedule, its quarterly report to the President and Congress, the same to be considered a public document and a report to the Filipino people. Thank you. Magandang hapon.
Thank you, Dr. Da Silva, our representative from ARTA, Mr. Bringas.
Yes, good afternoon. I am Attorney Eduardo Bingas, the Deputy Director General for Legal of ARTA. Although we were not provided for a copy of the will, I was listening intently on the comments, and I noticed that there's the power will be given to the President to privatize certain portions of PhilHealth. I'll just be on the lookout on the provision, the doctrine of delegata potestas non potest delegare, meaning that we should put limitations on the power that will be given to the President so that it will be regarded as unconstitutional later on. And also with regard to the privatization of the other section or portion of PhilHealth, what would be its effect in terms of their employment, because at this point they are considered as government employees. We have the same encountered similar problem at with regard to the duty free, because it was pronounced by the Supreme Court that the duty free employees are government employees, and that now the transition from private to public, particularly with regard to their insurance and benefits are now at stake. So perhaps you can take a look at this, and we reserve, ma'am, to make a formal our formal comment on the proposed bill. Thank you very much.
Thank you so much, Attorney Bringas. We can now hear from the author, Kong Stella.
Yes, salamat, Madam Chair. I'm very happy, Madam Chair, that the DOH is here. Pero before I ask questions on the social health insurance crisis, baka pwede po natin hinga ng pahayagang DOH on the public health crisis at the moment. Kasi hindi pa yata naririnig natin ang DOH tungkol po sa ating situation, COVID situation ngayon. So if we may digress just for a bit, baka sakaling DOH would have a public pronouncement on the current public health situation.
Yusek Mario.
Yes, the official pronouncement po ay lahat ay nanggagaling kay Yusek Rosette Berheire, and I think on a daily basis nabibigay naman po yung mga information na kakailanganin ng ating mamamayan at ang ating mga media practitioners. Opo. So atin na lang pong hintayin ang daily pronouncement na nanggagaling kay Yusek Berheire.
Sige
Siya
po,
po
on
yung
that note.
araw-araw ay may briefing na ginagawa. Opo.
Sige po, on that note, Madam Chair, tanungin ko na lang muna si Yusek Mar. Yusek Mar, kayo po ba ay naniniwala na meron na tayong social health insurance crisis at this point in time? Matagal na natin pinapanood or pinag-aaralan ang reforms. Madam Chair, matagal ko na pong kasama sa Yusek Mar since health sector reform agenda pa of Secretary Quezon Romualdez in the early 1990s. Yan din ang dahilan kung bakit ko po kilala si VP Waway, si Dr. Clem, si Dr. Shirley Domingo. Lahat po kami matagal na po, veterano na po dito sa reforms pagdating sa healthcare financing. At this point in time, Yusek Mar, would you agree doon sa aking basic premise na meron tayong krisis?
Sa akin pong personal na note, ito hindi naman official na point of view pa ng Department of Health kasi hindi ko pa na present o na-discuss itong proposed bill na to kay Secretary or sa the rest of the Execom. But from my point of view, well, because of the frequent changes in the leadership in PhilHealth, we can see that there are, areas na hindi kaagad nasasagutan ng PhilHealth, and I think that this is also due to the certain time for the learning curve, no? But ito nga nagiging cycle siya, no? Hindi na natin doon sa explanatory note, no, na kailangan na magkaroon ng reorganization and privatization of certain segments. Ang root cause ay failure of leadership and lack of technical expertise at the helm. But nagiging cycle ito kasi yung frequent na change din ng leadership at saka yung constant change in terms of the assignments of people within PhilHealth ay nakaka-apekto din po yan sa ating mga pag-develop ng mga policies, ng mga systems and guidelines, and how best we can implement the intent of the law creating PhilHealth. No? Ito pong mga several years na at alam ko pong matagal na tayo magkakasama na tinutulungan nyo kami nung nasa UP Econ pa kayo na maiayos yung ating health sector reform agenda, which eventually became a big legislation na nasa universal healthcare na yung ating mandato ngayon. No? Now, naiba rin po ang aking pananaw kung paano natin naayusin ang health system because parang lahat na ng ating mga dapat gawin ay inaayos natin, ginagawa natin. Pero ang nakikita ko po parang umiikot din tayo. No? So ang nakikita ko po siguro talagang mayroong major restructuring ng ating social health insurance program. Tingnan mabuti kung alin ang dapat na ipi-finance talaga ng PhilHealth or ng social health insurance program. Kasi sa ngayon po nakikita ko yung mga inefficiencies ng ating health system. And this efficiency can be traced to one of the root causes. Ito yung hindi clear yung delineation on who is financing what. No? Sa universal healthcare, medyo ito na-identify na pero kailangan pa rin ayusin yung buong sistema. Kasi sa ngayon, nakikita natin ano ba talaga yung sino ba talaga ang dapat na magbabayad sa kung anumang package or program of health services and ano yung appropriate na payment mechanism sa ating different package. No? At ito po naman nakikita ko na nire-raise din ninyo sa ating mga budget hearing, no? Katulad nung sa primary care package, sino ba talaga ang dapat na financing agent for certain types of packages, no? So yun po yung kailangan na nakikita kong kailangan i-delineate na mabuti who pays for what and what payment mechanism should be instituted para yung behavior ng both the providers, in this case yung healthcare facilities or health providers will behave the way that we would want na maging mas efficient and less yung ating mga fraud at saka yung gaming of the system. In the same manner na ganoon din po sa demand side yung consumers ng ating health services ay mag-behave according to the way our incentives as well as yung ating mga regulatory mechanisms are there. Medyo broad po itong aking sinabi pero ito pa yung mga kailangang ayusin natin at the operational level. Yun lang po, Kong Stella.
So Madam Chair, maganda po yung sinabi ni Yusek Mar no, na meron talagang mga reforms na napaka-importante pagdating sa actual design nung programa. Pero ang sabi ni Presidente Yeran earlier, hindi siya sang-ayon dun sa aking panukala. Ang sabi niya, dahil nandiyan naman ang GCG, na inaasahan ng PhilHealth na siyang mag-spearhead ng reforms. So itatanong ko po sa GCG, Attorney Morsha, Madam Chair, sa GCG ba merong experts pagdating sa health insurance?
Ma'am, we have the division chief here, Mr. Talusan, sila po yung sa kanila po nakatoka yung PhilHealth. Sir Arnold?
Oh, so it's a very general question.
Meron po.
So were you listening to the entire hearing this morning, attorney?
Yes po, ma'am.
So I'm sure you realize that technical ang pinag-uusapan natin.
Yes, ma'am.
Right? So yun ang tanong ko lang, very simple. Sa pagtingin mo ba, may kakayahan ng GCG na pag-usapan, balangkasin at ma-implementa ang nararapat na reforma para sa isang social health insurance program?
Ma'am, for me, speaking on personally, yung sa opinion ko po rin po dito, we could use assistance po pagdating sa institutions dealing with the social health insurance crisis. We could use assistance pagdating po dyan. And apart from the mandate po ng 10149 na we deal with the leadership of the different GOCCs, particularly with the technical aspect of social health insurance, we can use a little assistance po pagdating sa bagay na yun.
Oh, tama. Kasi wala naman health insurance expert na plantilla position sa GCG. Tama po?
Wala po.
So, yun
puro
yung point
corporate
ko lang.
governance officer po yung meron kami.
Tama po. So, yun naman ang point ko lang, Madam Chair. Ang hirap na, since ang sinasabi natin, ang problema natin ngayon is tila kakulangan ng expertise dahil nga sa bilis ng pagpalit, sa bilis ng turnover, katulad ng sinasabi ni VP Waway, ang bilis ng turnover halimbawa sa IT, talagang you really cannot keep experts within PhilHealth. So, wala rin naman yun doon sa GCG. Kaya sinasabi ko po, that's just to explain where I'm coming from. Baka dapat ma-outsource talaga from the private sector. And this is not new because government financial institutions in the country have been doing it. Siguro yun po ang first set of questions. And siguro just one last point kasi I understand na may mga questions on safeguards. Ako, I completely appreciate po lahat ng comments on safeguards. That's very important. Pero yung safeguards naman po, particularly on conflict of interest, etc., these are actually very standard safeguards in many of contracts. So hindi rin natin yan i-imbentohin. Madali na po sigurong ma-research yan. And tingin ko ang pinaka-importanting safeguard sa lahat is this is a power of, we are granting the power to the president. And for me, that's the most important safeguard. So as long as mataas po ang trust natin sa ating presidente, tingin ko that's the biggest safeguard. So yun na muna po, Madam Chair.
Kong Stella, thank you so much. Meron lang akong ilang clarificatory questions, no, being one of the principal author ng UHC, no. So syempre, gusto natin ma-ensure na hindi maapektuhan yung implementation, no. Kung dumating yung pagkakataon na this proposal will be enacted into law. So I have 4 questions. Number 1, under yung RA 11223 or the UHC Act provides in Chapter 3 provisions of National Health Insurance Program from Section 8 to 16 yata, and there are other provisions that involve PhilHealth in Section 18 among others. So will the passage of this bill affect any of the existing provisions?
Madam Chair, yung National Health Insurance Program, just a program, is a separate entity from the PhilHealth, which is the GOCC. So these are two separate things. So when you privatize the functions of PhilHealth, you don't do anything to the National Health Insurance Program. So yung mga provisions ng UHC pertain to the National Health Insurance Program. Kung anong itsura ng National Health Insurance Program. So lahat yon mariretain. Ang sinasabi lang natin na mapaprivatize is yung vehicle na nag-a-administer ng National Health Insurance Program. So short answer, it will not affect the provisions of the Universal Healthcare Law, Madam Chair.
Okay, thank you. Yun yung gusto natin na ma-ensure. Next question, is it possible yung sa section 12, I think, on the we have a generic language on the repealing clause. Will the passage of this bill may indirectly affect certain provisions of UHC law? We have that repealing clause, I think, in section 12. Alam naman natin pag gumagawa tayo ng mga proposal, generic provision yung ginagamit natin. So nakalagay dito all laws, executive orders, administrative rules and regulations or parts thereof which are inconsistent with the provisions of this act are hereby amended, repealed accordingly. So hindi ba indirectly this will affect certain provisions of UHC law?
Again, Madam Chair, because there's a clear bifurcation between the National Health Insurance Program, for which the UHC provisions apply, and the PhilHealth as a GOCC that administers the program, tingin ko po wala rin pong ganun. Well, that's my understanding, of course, pero I would defer to the committee's wisdom, of course, Madam Chair.
And then on section 10, yung sunset clause natin of the bill provides, yun na, yung sunset clause for the joint executive and legislative Social Health Insurance Crisis Commission. Is it not supposed to include as well the transition management team? I think lang, pagtingin ko lang po, baka kailangan.
Tama po, Madam Chair. I would agree with you po.
Okay. Meron pa po bang gustong magtanong sa ating mga members or other resource persons?
Madam Chair, siguro before the question, I was also very uncomfortable with yung use ko ng phrase na ng privatize, yung use ng word ng privatize. So if I may also propose amendments to my own bill para lang ma-clarify, para lang maging comfortable tayong lahat, no, na talagang malinaw na hindi natin pina-privatize isang social health insurance program, but we only want to outsource from the private sector certain segments if necessary.
Okay lang po sa ating author, no, since most of our resource persons doesn't have an official position paper, and siguro po baka meron pang way to improve pa yung ating proposal. If we can
motion.
Yes, Kongging.
Ako na lang magtutuloy kasi gutom na ako.
Sorry.
Madam Chair, with the kind indulgence of my friend Representative Stella Quimbo, to further discuss and improve this bill, can I make a motion?
Go ahead, Kongging.
Can we create a TWG para marinig natin lahat ng position ng agencies, whether it's private or government?
Second the motion.
I move that we create a technical working group. I so move, Madam Chair.
Second the motion, Madam Chair.
There's a motion to create a technical working group committee. Julie seconded. Is there any objection? Hearing none, the motion is approved. Sorry ha, nagutom po kayong lahat.
Walang kain to? Walang lunch, Madam Chair?
Next time dapat may pa-virtual lunch tayo, Comsec. Anyway.
Wala pang grab dyan, Madam Chair.
Next time po babawi ako. Sorry po ha. Sanay po ako hindi kumakain kaya nga po ganito na ako kapayat. Tamay kayo. Anyway, siguro lang kasi kanina na-mention ni before we adjourn, no, na-mention ni Sec Mario. Sec Mario.
Yes, ma'am.
You still have Sec. Sec, I hope yung Exicom magkaroon ng when is your next meeting ng Exicom?
Next Tuesday na po.
Next Tuesday.
Kasi I'm thinking of holding a technical working group sana meeting next week.
Baka po ako ang ipapadala ng DOH doon pag tungkol sa
Okay,
health
yes.
finance.
So if we can ask yung ating mga resource persons, concerned agencies to please prepare official position paper on the proposed bill. Meron akong related, kami ni Kong Joet Garcia, na bill, but this one is actually yung na-mention ni Yusek Mario kanina na recommendation, creation of health insurance review and assessment. So parang you're creating another body outside of the PhilHealth. So ito ay pinatter namin doon sa Korea setup na tripartite sila. Parang may tatlong separate offices. Yung policy making body, tapos yung payments, and then review and assessment, separate din siya. So I don't know kung related ba siya or separate, but magandang move natin na magkaroon tayo ng open discussion na on how can we really address in, of course, accordance din doon sa implementation ng ating existing na UHC Act, no? So while we're deliberating this proposed bill, I hope then ang DOH and PhilHealth will start implementing na yung National Health Insurance Program natin, especially the outpatient benefit package, with the clamor ng testing natin na sana i-cover ng PhilHealth, sana nakakasama. At yung paracetamol na sobrang nawawala na sa mga butika ngayon, supposed to be sa comprehensive outpatient benefit package, kasama yan doon sa under UHC law. So meron pa po ba tayong concern, ating mga members and resource persons? Maraming salamat. Yes, Yusek Mario.
Madam Chair, si Yusek Villaverde po. Opo. Yeah, I would completely agree with Kong Stella Quimbo doon sa medyo change of some terminology related to the word privatization. Kasi nung una kong makita yung sa explanatory note pa lang, sabi ko, naku, ipa-privatize nila ang PhilHealth, that defeats the purpose of a social insurance. Pero na-explain naman po ni Kong Stella na definitely iba yung outsourcing or some form of private entities running certain segments compared to the National Health Insurance Program. Ano? So yun lang po, dapat kailangan talagang maklarify yan doon sa proposed bill na ito.
Okay, so makikiusap po tayo na sana magbigay po kayo ng mga suggestions, official suggestions on the proposed bill, so that on the technical working group meeting ay refine po natin yung proposed bill. Any other concern?
Madam Chair.
Hi, Kong Jun, how are you? Hello po. Yes po. You're here pala.
Move to adjourn, Madam Chair. If there are no other matters to discuss.
Second.
Thank you so much. Your favorite motion to adjourn.
Madam Chair, next time, grab ang lunch.
Sige, Comsec. There's a motion to adjourn this meeting. Julie seconded. I'm sure wala mag-object, no?
Thank you, Madam Chair.
Salamat po sa inyong lahat.
Thank you, Madam Chair.
Happy New Year. Happy New Year.
Happy New Year,
Ingat kayo.
New Year, everyone.
Thank
Bye-bye.
you po for your active participation.
Thanks.
Salamat sa lahat.
Ingat,
Thank
ingat.
you.
Happy New Year.